as panelists. Dr. Dhananjay is there. So we start off with Dr. Darshan. Would you like to give your presentation? So you have 7 minutes, and then we'll have 3 minutes of discussion time. Okay, go ahead.
Am I audible?
Your voice is slightly lower. If you can just come close to the mic or increase the volume.
Good morning, everyone. So the topic of
Morning.
my paper is clinical and radiological outcomes following arthroscopic double suture pull-through fixation technique for acute comminuted PCL avulsion fractures, posterior cruciate ligament avulsion fractures. So, undisplaced PCL tibial avulsion fractures can be managed conservatively, whereas displaced required operative intervention to provide joint stability and prevent non-union of the fracture. There are many fixation options, both open and arthroscopic techniques described in the literature for PCL avulsion fractures. A single large non-comminuted fracture can be managed by cannulated screws with or without washers. But however, if the PCL avulsion fragment is comminuted and small, it is challenging to reduce and fix accurately with screws due to further fear of comminution while passing the screw. So some authors have described open reduction and fracture fixation with suture anchors for comminuted PCL avulsion fractures. This technique requires a careful dissection in the posterior aspect of the knee to approach the fracture. So more recently, arthroscopic suture fixation techniques for PCL avulsion have gained momentum. So objectives of my study were to retrospectively review and analyze the clinical and radiological outcomes of patients with comminuted PCL avulsion, and hypothesis that the arthroscopic fixation of comminuted PCL avulsion is a safe and reliable technique. The inclusion criteria was the patients which were skeletally mature who had acute less than 3 weeks of fracture with displaced and comminuted PCL avulsion fractures, displaced more than 3 mm from the fracture crater. Patients whose posterior door was grade 2 or 3 on clinical examination and who were treated by arthroscopic double suture pull-through technique. Exclusion criteria was the patients who had periarticular fractures, other ligaments injuries to the same side of the knee, to the same knee, like collateral injuries or corner injuries or multi-ligament injuries were excluded. PCL avulsion fixed by any other techniques were excluded, and associated neurovascular injuries to the knee were excluded. Coming to materials and methods, patients with acute PCL avulsion fractures who had been operated by arthroscopic double suture pull-through technique between the year 2009 and 2016, that is 8-year period, time period was taken, and a minimum of 2 years of follow-up were included in the study. Lisham and International Knee Documentation Committee scores were utilized to measure the clinical outcomes. Then knee laxity grading was assessed by manual posterior door test, and radiographic assessment was involved in the union status of the fracture. Standardized AP and lateral X-rays of the knee were taken. And coming to the surgery technique, the patient was in supine. Patient was operated in supine position under spinal or general anesthesia under tourniquet. Again, after anesthesia, a clinical examination was done under anesthesia to confirm the clinical findings. After standard preparation dripping, the standard anteromedial and anterolateral portals were established. Diagnostic arthroscopy was performed to confirm the findings. And then with the arthroscope in the anterolateral portal and knee in 90-degree of flexion on the table, entry to the posterior compartment of the knee was made, and through a slit created by shaving the fat between the ACL and PCL without damaging the ligaments. Then with the arthroscope viewing the posterior compartment through the ACL PCL window, 2 posteromedial portals were made, the posteromedial superior portal and the posteromedial inferior portal. And two plastic cannulas were inserted through these portals, and further through the ACL PCL window, the medium septum behind the PCL was excised using the power shaver. The arthroscope was shifted to the posteromedial superior portal, and debridement of the soft tissues around the fracture bed was carefully performed through the posteromedial inferior portal, and the hematoma around the fracture bed was removed, and the Evans fracture fragment was held by a suture retriever, and the reduction was attempted to assess the ease of reduction. Then the PCL tibial angle drill guide was placed about 5 mm distal to the level of fracture bed. 2 centimeter incision was made, 2 centimeter medial to the tibial tubercle, and two guide wires were drilled on the either side of the avulsion crater. As you can see this, like this. Then after that, 4.5 mm tunnel was drilled over the guide wires with cannulated drill bits, while protecting the tip of the guide wire by PCL wire catheter. Next, after this, two high-strength sutures were passed to the anteromedial portal, wrapping around the PCL, and the two limbs of the sutures were pulled out through the tunnels later, and then tied over each other. Then the tibia was pulled anteriorly to optimize the tension in the PCL, and the bony fragment was held with suture retriever from the posteromedial inferior portal to assist in the accurate reduction of the fragment into the crater while visualizing the reduction of the fracture through the posteromedial superior portal. And then the two suture limbs of each pair were sequentially tied over the bony bridge in between, keeping the knee in flexion. So this is how the surgery was performed. Coming to post-op rehabilitation. Uh, Sorry, yeah. This is the pre-operative X-ray and the immediate post-operative X-ray and the X-ray of a patient post 78 months of follow-up. Coming to post-op, all the patients in this study were put on an extension knee immobilizer with a modification of posterior tibial support to prevent the posterior tibial sac for 3 weeks. And static quadriceps strengthening exercises and active straight leg raising exercises were initiated immediately. The patients were kept non-weight bearing with bilateral auxiliary crutches for 6 weeks. Then active knee mobilization was initiated at 4th week, and gradual weight bearing was permitted at 7th week onwards. Return to pre-injury activities or sports activities was allowed only at the end of 6 months. So out of the 23 patients at the final follow-up, there were 19 males and 4 females. The mode of injury was road traffic accident in 19 cases and fall from stairs in 4 cases. The mean duration between injury and surgery was 9.43 days, ranging from 2 to 21 days. And the mean duration of follow-up was 56.5 months, ranging from 24 to 84 months. At final follow-up, the mean Lishom score was 94.9. That is excellent. Then the mean subjective IKDC score was 84.84, whereas the objective IKDC is grading revealed grade A in 10 patients, grade B in 11 patients, and grade C in 2 patients. On manual posterior drawer testing, knee laxity in 21 patients was graded as grade 0, and the remaining 2 patients had grade 1 of knee laxity. So the fracture had united on radiographic assessment. Fracture had united in all.
You have 1 more minute.
Yes, sir. On radiographic assessment, the fracture had united in all the cases by the end of 12 weeks, except one, which went for non-union. All patients regained full range of range of movement at the knee, except 4 patients who had loss of flexion range of movements. No patient had flexion deformity. There was no wound-related or any neurovascular complications noted. So coming to the conclusion of the study, that is in PCL avulsion fractures, if the fracture is displaced, small or comminuted, the arthroscopic dual tunnel double suture pull-through technique described above, even though technically demanding, appears to be a reliable and stable, minimally invasive technique which restores the stability and function of the knee. However, the development of arthrophyrosis is a remote possibility in small percentage of cases. So these are the references. Thank you, sir.
Great. Thank you, Dr. Darshan. That was a great presentation. So you had a total of 23 patients.
Can I ask a question, Maninder?
Sure,
Yes, sir. Total of 28 patients. Yes, sir.
Sorry, Maninder, you had asked a question. Sorry, you please go ahead.
Yeah, it's you had a total of how many patients? You said 23 patients?
The time period included was 2000. Over 8 years, 28 patients were operated with the same technique.
Okay.
However, 5 patients were lost to follow-up. So 23
Okay.
patients were included in the study.
Right. Yes, Dr. Dhananjay, please.
So over the period of 8 years, it's the single surgeon who had done all the surgeries, or they
Yes,
had
sir.
multiple
Single
surgeons?
surgeon.
Single surgeon.
Yes, sir.
If you look at the technical aspect of this procedure, it is not something which is very simple. I mean,
Yes,
as such, entering into the posterior compartment and try to piece it together is going to be quite a challenging task. So definitely the surgical technique is something which is not for everyone. But I think
Yes,
I'm pretty sure it has been executed very well. But you said that you tie the sutures in flexion, and that gives you a better reduction.
Yes, sir.
But we
Over the
immobilize them.
bony bridge.
We immobilize them in extension, isn't it?
Yes, sir.
So we mobilize them in extension so as to minimize the stress coming onto our repair, but we reduce them in flexion. That is something, okay, fine. I think I'll have to go back to my books then. Fine, Chief. Thank you so much. Marinder, that's it.
Thank you so much, sir.
Dr. Darshan, you said you pre-operatively you're testing, you're doing within 3 weeks of this injury, and you're
Yes, sir.
testing all patients with the posterior rod test to elucidate whether these patients require a surgery or not. My question is, how many patients were you able to really test at 3 weeks? Because most of these patients are supposed to have a lot of pain in their knee with the um, avulsion of PCL and especially comminuted avulsion that you have in your case. Is it really possible to do a posterior rod test in a patient with the acute PCL injury?
Not in all patients, sir, but patients were again assessed. Clinical assessment was done in operation theater under anesthesia.
So it was once you had already taken the decision to operate the patients that you did the examination for your inclusion, right?
Yes, sir. Yes, sir.
And what is your definition of comminuted PCL? Is it 2 fragments, 3 fragments, 4 fragments, 5 fragments? How big fragments?
3 to 4 fragments or more fragments.
So what was
3
the
and more.
average number?
3 and more.
What was the average number of fragments in your 23 patients?
Not calculated.
That should have been done
Yes,
because
sir.
for all such thing that is done. Another flaw that I see in your studies, you say all the patients had union in 3 months at 12 weeks. How do you look for union in these patients?
For union, they were assessed radiographically, sir. Standard AP and lateral view was taken.
That is certainly not enough, because if you get a good reduction on the immediate post-operative X-ray, I don't think there will be any difference between the X-ray done on day 1 or the X-ray done at 3 months. How do you see whether there is union or not? Because essentially you're just looking at a number of fragments on the posterior part of the knee. AP
Yes,
view
sir.
certainly will not show you anything at all, because you can even miss a PCL injury on an AP view. And if you've done a good repair in a lateral view on day 1 after the post-operative period, also it would look healed. Have you done a CT scan or something to elucidate whether there is union or not? Because I'm not sure if X-ray done at 3 months from a lateral view of the knee can tell you really whether the PCL has united or not.
Post-operatively, no CT scan was done for any patient. Pre-operatively, CT scan was done.
That is certainly a limitation in your study, because even though you think that there is union, a lot of people may still challenge that there is union or not at 3 months, because it is almost impossible to see for union at 3 months for a small PCL avulsion. It is not a big fracture. Thank you, Dr. Darshan.
Okay. So, Dr. Darshan, couple of comments. Did you answer Dr. Samat's question? Are you okay with his comments? I think we've lost him.
Should we go on to the next, sir?
Okay. Yeah. So can we invite? So just a couple of comments on Dr. Darshan's study. I think he's had a good study, good follow-up. I would do a functional scores. He's done LISOM and IDC scores. Maybe a functional score like an SM36 will add to the study, and maybe another arm comparing to modes of fixation would be over this long period. I think will be great. So that's just the two comments to improve on the quality of the study. So thank you. Next, can I ask Dr. Aditya?
Good morning, sir. Yes, sir.
Morning.
Aditya, you can share your screen. You have 7 minutes starting now.
Yes, sir. Is my screen visible, sir?
Yes.
Yes.
Good morning, everybody. I'll be presenting on the variables affecting the functional outcome in floating knee injuries. So basically, floating knee was described by Blake and McBride. It is a high velocity injury with a complex fracture pattern. It has generally a number of associated injuries and has got an unpredictable functional outcome. Are my slides visible, sir?
Yes, we can see them.
Okay. Floating knee was basically classified by Fraser's or modified Fraser's classification or based on the location of the fracture, extensor apparatus involvement, associated injuries, ligamentous injuries. So this study was designed to evaluate the association of different variables affecting the clinico-radiological and functional outcome of floating knee injuries. So just in short, Fraser classification, type 1 will be extra-articular fracture of both the femur and tibia. Type 2A is the femoral shaft and tibial plateau fracture. 2B is the distal femur and the shaft of tibia fracture. And type 2C is the fracture of distal femur and tibia plateau, intra-articular of both. Modified fracture classification given by Ran et al., where type 1 is the extra-articular fracture, type 2 articular surface, whether simple or complex, and type 3 is when patella is involved. So coming to the materials and methods of the study, it was a retrospective study. Total of 89 patients, including 90 floating knees, over a period of 4 years were included. Skeletally immature and pathological fractures were excluded. Functional assessment was done after minimum 1 year of follow-up, and it was done using Karlstrom and Allegrud criteria. So the management protocol basically of 89 patients, after 80 LS, 44 were stable and 45 were unstable. Unstable were managed using a damage control orthopedics and primarily X-fix and vascular repair and amputation in some cases. The stable fractures were managed by the diaphyseal fracture by nailing or DCP-LCP and metaphyseal epiphyseal fracture by periarticular LCP or screw fixation. Coming to the variables analyzed, so age, gender, side, open or closed, segmental, union status, and intra-articular fractures were the variable analyzed. The outcomes were compared with knee stiffness, shortening, malalignment, functional outcomes.
Dr. Aditya, are you sharing your screen? Because I am unable to see your slides.
Just 1 second, sir. I'll reshare it again.
Maninder sir, are you able to see the slides?
No, I can't. We just need to
Just
share
1
it
second.
again.
Yes, sir. Is it visible now, sir?
Yes.
Yes. Please go ahead.
Okay. So the variables analyzed in this study were basically categorically age, gender, side, open or closed, segmental fractures, union status, and it was compared with the outcome variables of knee stiffness, shortening, malalignment, and functional outcome analyzed by SPSS software. So basically the Karlstrom and Olegrude criteria based on the subjective complaints from knee, thigh, leg, knee, ankle based on walking ability, work and sports, and objective criteria including angular rotational deformity, shortening, and range of movement of joint. They were graded as excellent, good, fair, and poor. So coming to the result, the male-female ratio was 81:8, right side in 73 and left in 17. All had an history of road traffic accident. The mean age was 34.34. Patella fracture was present in 17 cases. Open tibia was 55 cases and open femur was 38 cases. 16 fractures were segmental each. The associated injuries include other fractures mostly, also head injury, pelvic injury, chest injury, facial injury in some cases. So coming to the results of bony union, as you can see, the 42 fractures of tibia had a mean union time of 5.4 and were considered as united. 29 fractures had a time of 10.34, were considered as delayed union, and 12 fractures showed non-union. Similarly, in femur, 43 fractures were united, 24 were delayed union, and 16 non-union. Coming to the segmental fractures, for the segmental fracture of tibia, so the fractures with and without segmental fracture showed an average union time which was similar, not statistically significant. And for the segmental fractures of femur, the time was statistically significant. Coming to the open fracture and union time, for the open fracture of tibia, as the grading increased, the time for the union went on increasing, while for the femur, it was almost the same for all categories. Additional procedures, which were bone grafting of femur tibia, refixation, were required in some cases. It showed that segmental fractures required more additional procedures. Complications immediate 29 cases, which included vascular injury, bone loss, and amputation in some cases, and delayed complication mainly osteomyelitis of tibia, and in some cases knee instability, foot drop, and osteomyelitis of femur. When we analyzed the Fraser classification, there was found that the functional outcome was similar in almost all of the Fraser criteria. So there was no correlation between the Fraser's classification and the Karlstrom criteria. The risk factors which were assessed at the end of study, which showed to have a significant association with the outcome, were open tibia fractures, open femur fractures, intra-articular fractures, fractures requiring additional procedures like spanning exfix, and segmental fractures. On the contrary, extensor apparatus injury or the gender or the side of injury or time to union showed no relation to the functional outcomes. These are some of the cases with Fraser type 1 which showed an excellent outcome. A case of Fraser type 2B which showed a fair outcome. So coming to the discussion part, floating knee injury is a high velocity injury with a male predominance. Associated injuries are very common and should be treated immediately. Early management should be based on the principles of damage control orthopedics. Stable fixation will help for early mobilization. Retrograde kneeling has shown to be some advantage. Non-union joint stiffness and infections are the common complication, and asymptomatic knee instability may be noted. Coming to this study, the limitation was it was only a retrospective study with a shorter follow-up of 1 year. A longer follow-up in a study could help to identify degenerative changes. The strength of the study, where it was a large series with a single center based on a standard protocol, and the same team of trained trauma surgeons operated all the cases. So in the end, concluding, the poor prognostic indicators for floating knee injury include open tibia fractures, segmental femur fractures, intra-articular fractures, and fractures requiring additional surgical procedures. So an ideal classification system for a floating knee should be considering the soft tissue, ligamentous or open injuries, and also the complexity of fracture pattern. And surgical treatment method can also impact the outcome. That's it, sir. Thank you.
Yeah, thank you, Dr. Aditya. Thank you for sticking to the time. I think that was an excellent study, an excellent presentation. Dr. Samarth, you want to ask anything?
Yeah. So, Dr. Aditya, good presentation. You have a huge number of patients, 79 patients is a good amount of patients. I'm assuming these were not all done when you were there because you were a junior resident and the study is done over a period of 4 years.
Yes, sir.
So, my question to you is, from the conclusions of your study, I don't see any relation to the in terms of prognosis with the fracture of patella. Have you seen separately in respect to fractures of patella whether the
Yes,
functional
the fracture of patella was present in 17 cases, and that outcome wasn't significant. That statistical difference wasn't found to be significant.
Which is completely in contrast to most literature, because
Yes, sir.
in simplified classification they have come up. The last grade is any extra-articular fracture of femur or tibia with a patella fracture, because most studies feel that the moment a patella fracture happens in a floating knee injury, the prognosis becomes really, really, really poor. Another thing is, did you look for an MR Did you do an MR in the knee of these patients? Because it is a known fact that a lot of patients, around 75% of these patients, tend to have meniscal injuries, associated ligamentous injuries, or ACL and PCL avulsions.
No, sir, MR wasn't done. This will be a limitation of the study because this associated knee injuries weren't considered.
Okay. And did any of these patients happen to have a floating hip injury as well, like a acetabulum fracture or neck of femur fracture? Because we know from our experience that around 16 to 17%, if not 25% of isolated femur fractures can have neck femur fractures. And with such significant injury and open fractures in your cases, there is still a
No, sir.
likelihood of...
No, associated hip dislocations or other neck of femur fracture were not considered.
Okay.
Thank you. Thank you, Dr. Aditya. I think that was good. What I would like to just say about the study was, it's sort of over a 4-year period, but you look at it retrospectively, isn't it?
Yes, sir.
I think yes, but the thing about the study is that you found that the functional outcome was not affected by the fracture type or the severity of the fracture pattern, and
Yes,
I think
sir.
that's a bit unusual. But I think that's good to know. Is that agree with the previous literature?
Sir, literature reports are contrary. Most of them suggest that they correlate with fracture classification, but some studies have shown that they do not have any correlation.
Okay, fine. Thank you so much. Thank you for the presentation. Now we'd like to call upon, is Dr. Surinder here? Next, Dr. Rakesh. Oh, Dr. Surinder is here. Yeah. Okay, please start your presentation, Dr. Surinder. You have 7 minutes.
Yes, sir. Dr. Rakesh here, sir.
I think Dr. Surinder is here, so he's
Okay,
going to
sir.
start. Yeah.
Fine, sir.
Call you next.
Good morning, sir.
Good morning. You have 7 minutes, Dr. Surinder. Thank you.
This is Dr. Surinder, third year resident, PGIMS, Rohtak. Today I'll be discussing about the malignant and aggressive bone tumor around the knee treated with innovative rotation plasty. In orthopedic oncology, what challenges we face is resection of the tumor, reconstruction of the limb, complication, and their
ऊपर नहीं आ रहा मेरे.
treatment. Treatment should be cost effective, durable, and innovative. Most of the bone tumor or sarcomas commonly occur around the knee joint. There are different modalities for the treatment of these sarcomas, including the amputation or limb. The concept of rotation plasty was given by Borgrave for the proximal femoral defect in the settings of tuberculosis of the proximal femur. Then the concept of rotation plasty was further used by Kirsten, Kahan, and Selzer for the sarcomas of the distal femur. Later on, subsequent modifications were done, and these were used for the further sarcomas around the knee joint and proximal femur also. What we done in rotation plasty, we excise the tumor around the knee joint or proximal femur and rotate the part of the limb at 180 joint now work as the knee joint, or the knee joint start to work as the hip joint. According to Winkleson classification, there are 5 subcategories, 5 type: A1, A2, B1, B2, and B3. For knee, we have for the tumors around the knee, we use A1 and A2 type, where we excise the tumor in block with the distal femur, proximal tibia along with the knee joint, and we rotate the distal part of the leg at 180 degree and reattach it to the proximal part and reattach it to the proximal part, and osteosynthesis was
I think we were not able to hear you for the last minute or so. Dr. Surinder, I think he's gone offline. Shall we continue? Dr. Rakesh, do you want to start off with your presentation, and we'll take Dr. Surinder later on? I think he's having some connection problems. Please unmute yourself, Dr. Rakesh.
Okay, sir.
Yeah, please start.
Should I share my screen?
Yeah. Just 7 minutes.
Are you able to see my screen, sir?
No, we can't.
Okay, Dr. Rakesh, we can see your screen. Go ahead, 7 minutes.
Okay, sir. So myself, Dr. Rakesh, in Department of Orthopaedics, PGIMS Rohtak, third year PG.
Just go to the slideshow mode. Go to the slideshow mode.
Slides?
Slideshow mode. You are on the normal mode. Just go to the slideshow mode. Slideshow. No. The slideshow on the PowerPoint itself. Go back to the PowerPoint.
Presentation mode. The presentation mode.
It is right at the bottom where the percentage sign is there. The button just next to it. On the right hand side. On the right. Yeah. Next button. Next. The third button. Yeah, this one.
Thank you.
Yeah.
It's fine,
Right.
sir?
Perfect.
Thank you very much, sir. Today my topic is minimally invasive technique for delayed union or non-union fracture. The use of percutaneous autologous bone marrow injection. Fractures heals by a specialized process in which bone regenerates by restoring the integrity of skeletal tissue. Healing could be primary or secondary, relying upon the rigidity of fixation, with most fractures exhibiting both types of healing. The time within which a fracture can unite varies with the age, special species, type of bone, fracture pattern, accompanying soft tissue destruction, and any associated general illness. And delayed union and non-union are the most other common issues that any orthopedist might face addressing fracture healing. It is common in treatment of long bones, particularly tibia. Causes of non-union may be local, general, or mechanical. Impaired fracture healing is predicted to occur in 5-10% of all fractures, and the incidence nearly doubles in case of open fractures and fractures with soft tissue injuries. In the non-union of fractures, healing cascade has ceased and it will not progress without an intervention. Autologous bone marrow grafts are regarded as gold standard for treating non-unions. Recently, there has been a trend towards a lesser invasive techniques in which the bone marrow can be aspirated from the iliac bone by needle aspiration and it is administered percutaneously at the non-unions of the non-union site. Injections were re-administered after 4 to 6 weeks if there was no imaging proof of callus formation seen. The procedure was thought to be a failure if there was no clinical and radiological signs of union seen at 6 weeks following the third injection. Follow-up was done at monthly interval for 3 months in our study, and then the 6th month following the bone marrow injection. Patients were evaluated both clinically and radiologically at the follow-ups as per radiographic union scale in tibia fracture score, RUST score. These are RUST score. It's what the calyx is absent or present. The fracture line is visible or radiologically or invisible. It is showing how to give injection in the percutaneous autologous bone marrow in the non-union site. It's basically done on the CT scan, and the injection is injected. Our study was prospective in nature, in which we take 30 cases of post-traumatic patients in which the delayed union or non-union of fracture tibia with internal fixation was having. Baseline error scoring was calculated for each fracture, and bone marrow aspirate injections were given at the fracture site by the percutaneous route. something about the operative techniques. This procedure can be performed on a day-to-day basis under local anesthesia. There is minimal pain. The position of patient is supine, and the aseptic conditions should be taken. And recipient sites are prepared and address the donor site and drape separately both the sites. About 2 to 3 millimeter incision was made over the iliac bone crust, and needle was inserted in the multiple areas of posterior bone crust to aspirate the bone marrow. Bone marrow aspiration needle was connected to a 20 cubic centimeter syringe. Heparination was done. About 15 to 20 ml of marrow was aspirated from one side, and multiple aspirates were done with a minimum of 40 to 150 ml of the bone marrow was harvested. Under CM microtoma was created, employing a needle at non-union site, and the aspirated marrow was injected percutaneously at the recipient fracture site, as I show in the picture below. Then the slab or brace were given after the bone marrow injection to immobilize the recipient graft site. Aseptic dressing was done at the site, and then patient was elevated after 4 to 6 weeks. This is the instrument to use in this technique, and it's the CM guided technique. The results. In our results, the union, we found union in 23 patients. There's 76.6% of our patients. We were having 30 patients. Whereas the 7 patients, which are around 24%, did not respond even after 3 attempts of the procedure. The complication of the procedure are negligible, and it is very safe and day-care basis. The mean time of radiological union in our study was 14 weeks, with a range of 11 to 22 weeks. This is the case. We done autologous bone marrow aspiration at the 8 weeks, then result at 12 weeks, and after the 6 months. So we found out that autologous bone marrow injection is an efficient method compared to traditional open bone grafting. It is a very less invasive technique which can be performed as an outpatient procedure under local anesthesia with negligible complication rate at donor recipient site graft site. Thank you, sir.
Okay, thank you, Dr. Rakesh. I think that was a good study. So just one question from my side is, when did you decide that this was a delayed union or non-union? How did you decide that? Sorry, I missed it if you have already presented it.
So after the 6 months of a patient, if there is no callus in the fracture site.
Okay.
Dr. Rakesh, so what are your inclusion criteria considering this is a prospective study? Because non-union can have a lot of causes. If there is displacement, distraction at the fracture site, then I don't think any bone marrow or any form of therapy would work, and it would require a refixation. How did you rule out infection in your patients? Because infection can be another low-lying, low-grade infection. So I essentially want to know all the detailed inclusion criteria.
So actually, we did a CRP and ESR if the patient, if that is normal, that is in our inclusion criteria. If there is little bit gap in the patient and it is radiologically inclined, then we take that patient. If there is no callus after the first 6 months, like it's going in non-union or delayed union.
And were any extra procedures done at the same time, point of time, like dynamizing the nail or doing a fibulectomy or any procedure?
No, sir. Only that is the bone marrow injection.
And what was the average time period in your 30 patients between fixation and the first bone marrow injection?
So basically, we got around 11 weeks is the normal average time. Like 50% patients who got fractured union in our study.
No,
after 11 weeks.
No. I'm asking what was the average time between the initial fixation and your bone marrow injection? Patient came
Sorry, sir, I didn't get you.
A patient came with a fracture of tibia. You've put in a nail, you fix the fracture, and then you label it as non-union, and then you give your bone marrow injection. Isn't that right?
Yes, sir.
So what is the average time period for, so suppose you have 30 patients, all of them operated on 1st of January. What is the average time when
6
all
months,
of these
sir.
patients?
6 months.
But that is the minimum criteria you said to label them as non-union. How can all of them have average time period of 6 months when that is
Okay,
the
average time
minimum?
of the whole patient. Yes, sir, around 8 to 9 months, sir.
Okay. Thank you.
Okay, thank you, sir.
Okay, thank you, Dr. Rakesh. I think we'll move on.
Yes, sir. Thank you very much, sir.
Is Dr. Surendra, are you ready again with your presentation? We lost you last time. Dr. Rakesh, please stop sharing.
Okay, sir.
Okay, Dr. Rakesh. Dr. Surendra, do you want to share your slides now? Go ahead, Dr. Surendra. You need to unmute yourself. Dr. Surendra, you need to unmute yourself. Okay, go ahead. Go ahead, Dr. Surendra. We are unable to hear you, Dr. Surendra.
Yeah, I think there's some connection problems maybe. I don't think he's got a very good internet connection.
Sir, should we go on to the next?
Okay, I think we've got Dr. Sandesh on the line. Dr. Surendra will come back to you later. Please try and sort out the connection issues, and we'll come back to you later after Dr. Sandesh's presentation.
Can you hear me, sir?
Yes, we can hear you, but we keep losing you.
Okay, Dr. Surendra, go ahead. Sir, should we go to the next presenter?
Yeah, please. I think Dr. Sandesh, are you ready with your presentation?
Yes, sir.
Please.
Can you hear me, sir?
Yes, please.
Just a second, sir. I'll be sharing my screen.
Okay.
So can you see my screen, sir? It's a screen share.
Not at the moment, but I think it's in this.
Can you see it?
No, not as yet.
No, it just says that it started screen sharing. You can't see it as yet.
Just a second, sir.
So just stop it and do it again.
Yes.
Yeah, we can see it now.
So can you see it now?
Yeah.
Okay. So good morning, sir.
Your audio is not very clear. Do you have any speaker in the background or something?
Yes, sir.
I would suggest just disconnect all your mics and just go
Yeah.
to the
Dr. Sandesh, you'll have to reshare the screen.
Yeah, yes, sir. Yes, I'm doing that. So just a second, sir. I'm not able to reshare it. I'll just copy it again. So can you just give me 2 minutes? I'll just get back. I'll just.
Okay. And Dr. Samarth, do we have any other presenters?
Sir, I think this was the last. Is there any presenter left for this session?
Dr. Samarth,
Yes, sir.
there were total 5 speakers in this particular session.
Yes, sir.
So
Yeah.
have they all presented? There were some glitches because presentation breakdown.
We've had 3 presenters already completed their talk. One we lost. Dr. Surinder was not able to. Dr. Sandesh also is having some issues.
So I think we can guide them. They can just delink themselves and then again link in again or something.
Yeah, that's what try to do now. Yeah.
Because if we have to give them certificates, we want their presentations on board.
Dr. Surinder started and then did partial presentation, and then we lost him after that.
But I'm sure that your next session, the poster session, people they have lined up, I guess.
Yes, yes, they have, sir.
Wonderful, wonderful. Great going, guys.
Sir, can you hear me, sir?
Yes, we can, Dr. Sandesh.
Sir, I'm not able to share my screen, sir.
Are you on a mobile?
No, sir, I'm on laptop.
Okay.
Just check your internet connection.
Okay, sir.
I can hear an echo of my voice when I'm talking to you. Maybe you have the same thing open at 2 places, so close it in one place.
I think what you have is 2 mics connected or something to the.
No, sir, I just have one.
So just disconnect the mic. Just keep the laptop only.
Can you hear me, sir? Better? Is it better, sir?
So disconnect your speakers and your mics on the laptop, and I think that should work.
We can move ahead if there's sharing.
Dr. Surender, if you are ready, we could go ahead with you. Dr. Surender, you can share your screen and you can go ahead if you want to, because Dr. Sandesh is also having trouble.
Hello.
Yes, Dr. Surinder, please go ahead.
Sorry, sir. Actually, there is no electricity, so Wi-Fi connection is not working. I'm working from the phone only.
Okay, go ahead. We can hear you right now.
Okay, sir. Can you hear me, sir?
Yeah, go ahead.
Okay. I'm Dr. Surinder Jaiswal, third year resident, PGIMS, Rohtak. Today I'll be discussing about the malignant and aggressive bone tumor around the knee.
We can't see your slides. We can just see your folder. Need to open your presentation.
Sorry, sir, I'm just having. So can I present with this PDF file only?
Yeah, carry on.
Hello.
Yes, with the PDF, yes, but
Hello?
we can't see the PDF. We can just see the
Okay,
folder. I think you've selected
I
the
will be
wrong.
talking about the malignant and aggressive bone tumor around the knee treated with the innovative rotation.
So stop sharing and then share the PDF file. You've shared the folder. Have stopped your sharing. And now share your PDF file. No, it's still again the folder only.
Can you see the slides, sir?
No, we can't see the PDF file.
Okay, sir. Can you see, sir? No.
No. We just have 4 minutes left for the next session to start. So, Dr. Dhananjay, what should we wind up the session here? Then I think we are not able to.
Sir, can I try it now, sir?
Dr. Sandesh, are you ready?
Yes, sir.
Okay. You won't have 7 minutes. Okay, you have 3 minutes to
Yeah, sure.
do it. Okay.
Yeah.
Dr. Surinder will stop from your end. Sorry about that. I think it's not working. Share your screen, Dr. Sandesh.
Yeah, I'm doing it. So can you see it, sir?
No.
So can you see it now, sir?
No, we can't.
So now, can you just present it like that itself, sir? I'm not able to share it.
Okay, yeah, start off then, and then.
I think you can see it now, sir.
No, we can't see.
Okay, so fine. I'll just start off with that. Good morning, sir. My topic for today is a functional outcome and intratrochanteric fractures treated with proximal femoral nating and the role of tip apex distance. It is a retrospective study under the guidance of Dr. Nagmaster. I'm presenting from Maharajappa, Kolar. Coming to introduction, intratrochanteric fractures are one of the most commonly encountered fractures in the orthopedic history. Due to unstable fractures, proximal femoral nailing has become has a better outcome in terms of. So just a second, I'm not able to. Okay. PFN has become as a better outcome in terms of rotational stability and this one. So aims and objective is to determine the role of tip apex distance in proximal femoral nailing, whereas the tip apex distance role is very well established in DHS. Coming to the methodology, it's a retrospective hospital-based study conducted in the hospital RL Jalaka from the year 2016 to 2018. Coming to methodology, so can you hear me?
Yeah.
Yeah. Coming to methodology and inclusion criteria, we have patients aged more than 18 years, that is after maturation. Then intratrochanteric fractures treated with proximal femoral nailing. Exclusion criteria, we exclude all the open fractures, patients with associated medical illness, associated neurovascular injuries, and pathological fractures. So coming to the criteria, how I measured the tip apex distance, I marked point A, that is where the center of line at the junction of head meeting the neck. From there, we drew a straight line along the axis of the neck of the femur, meeting the head. And from the tip of the lax screw, we measured the distance in AP, and posterior view. Coming to the results, we based on age, sex, mode of injury, and Harris score. We had about we did a study based. We got 57 patients in which we had most of the patients belong to age 71 to 80 years. Female in general, we had males about 35 and females about 25 patients. And in Harris score was calculated at 1 year post surgery. The average Harris score was graded as poor, which is less than 70, fair, which is 71 to 80, good, which is 81 to 90, and excellent, which is 91 to 100. So out of the study, we got that the mean average in patients with poor Harris score, that is less than 70, was one person in whom the tip apex distance was 28.3. And the average score in patients with the average score with fair counted, we had tip apex distance of average of 13.4 AP and 11.8 in lateral. And Harris score in good patients, we had about 12.7 in AP and average of 23.6. And Harris score excellent patients, the tip apex distance were 23.1 on average. This is a graph showing the tip apex distance and the correlation with the Harris score. Coming to discussion. The unstable intratrochanteric femur fractures in elderly with osteoporosis need early fixation and mobilization to prevent morbidity and mortality. The intramedullary knee device has many advantages in terms of small surgical wound, easy implant insertion, and stable fixation. According to the reduction criteria modified by Wagner, most unstable fractures could only be achieved by acceptable reduction, that is good alignment, and posterior medial cortex continuity. On the conclusion, the role of tip apex distance is well established in case of DHS, while the role of tip apex distance in PFN is not much established. In this, tip apex distance of less than 25 mm has a good value and better outcome in determining the outcome of intratrochanteric fractures treated with proximal femoral nailing. Most cases with complications in our case had a tip apex distance of more than 27. Fracture reduction with positive medial cortex support and valgus alignment allows limited sliding of the head neck fractures to contact with femur shaft and achieve secondary stability, providing good mechanism of environment for fracture healing. The limitations of our study was, it was a retrospective study. The sample size was relatively small and associated comorbidities were not taken into account. And these are my references.
Okay, thank you, Dr. Sandesh. Your audio was slightly poor, so we could not catch quite a lot of the points that you said. but thank you for doing it. I think we have finished the time for this session, so we'll move on to the next session. And we've had a really excellent presentations in this session. So thank you to all the speakers for being here at this early time. We move on to the next session, which is the poster session. And we have around 14 posters. And we have Dr. Rabindra. Welcome, Dr. Rabindra, as a panelist in our session here today. And I would request Dr. Samat to start the session and invite the speakers.
Thank you, Dr. Maninder. Welcome to our panelists for this session. Without wasting much time, I would request Dr. Nishank to go ahead with his first poster presentation, 3 minutes, and 1 minute for discussion after that.
Good morning, everyone. Am I audible?
Yes, you are, Nishank.
Yes.
And I hope the presentation is visible as well.
Perfect.
Thank you so much. So greetings from AIMS New Delhi. I'll be sharing our experience with an ERAS protocol in spine surgery at our institute. So what is ERAS? ERAS stands for Enhanced Recovery After Surgery. It is a departure from the traditional surgeon-centric approach towards a more patient-centric approach to healthcare management. Essentially, it involves seamless integration across different stages of a patient surgical journey and streamlining collaboration between multiple disciplines involved in patient care. It has been successfully validated in various surgical disciplines across the world, but there is limited evidence to support its use in spine surgery so far. Our study is the first to explore the use of ERAS in the context of a developing country settings. Our objectives were, first, to design an evidence-based ERAS protocol for elective lumbar spine fusion, and number two, to compare its results with conventional perioperative patient care that we are all used to. ERAS was implemented in our hospital in December 2016. Patients operated before that constituted the pre-ERAS or the control group, and patients operated after that constituted the post-ERAS or the intervention group. This was a retrospective analysis of adult patients who underwent 1 to 3 level elective TLIF, either by open or MIS approach. The ERAS pathway components were selected on the basis of evidence in literature, the prevalent hospital facilities, and local practices. The selected outcome measures for comparison were the length of hospital stay, post-operative complications, the 60-day reoperation and readmission rate, and patient-reported outcome measures in the form of VAS and ODI scores. So out of a total of 800 patients, 490 patients belong to the pre-ERAS group, 310 belong to the post-ERAS group. There was no difference in baseline variables. What we observed was a shorter length of hospital stay in the ERAS group without there being any increase in the post-op complications or the 60-day readmission and reoperation rates. In addition, we also observed lower VAS and ODI scores at 4 weeks in the ERAS group without any significant difference at longer follow-up. To summarize, a comprehensive 28-component ERAS protocol was successfully formulated in the setting of a public healthcare facility in a developing country. Implementation of this protocol led to shorter length of hospital stay and better functional outcome at early follow-up without increasing the incidence of complications or the rate of reoperation. I thank you for your attention.
Thank you, Nishank. So my question is, if you were following all the 28 components of the ERAS, how were you able to convince your anesthetist to allow the patients to drink water up to 2 hours before surgery? And were you also doing carbohydrate loading for these patients preoperatively?
Sir, we also had 2 anesthetists who came to our OT as a part of our team during the designing of the ERAS pathway, and that is why we were able to convince them during their specific pre-anesthetic checkup to allow for this instruction. And number 2, yes, carbohydrate loading was also a part of our ERAS pathway.
Dr. Maninder, any questions for him, sir?
No, I think that was an excellent presentation.
Thank you, sir.
Dr. Ravindra, do you have anything you want to ask?
Thank you, Nishank. Very good presentation. We'll go on to the next speaker, Dr. Vivesh Kumar Singh, who would be speaking upon replacement surgery in skeletal dysplasia, need of spinal evaluation, his case report. And Dr. Vivesh, your 3 minutes will start as soon as you start sharing your screen.
Okay, sir. Good morning, sir. Today my topic for today's topic is replacement surgery in skeleton dysplasia need of spinal evaluation. A case report. Uh, Skeleton dysplasia are a heterogeneous group of disorder that have in common a defect in bone formation or remodeling, thus leading to abnormal biomechanics and various spinal and joint manifestation. In this, this is a case of a 25-year-old female which presented to us after bilateral THR along with a bilateral adductus tendectomy with severe hamstring tightness. On examination by spine surgeon at our institute, it was found that the patient has spastic quadriparesis with restricted neck range of motion and positive lemmathes sign. Patient had a range of motion on both knees of 60 to 120 degrees with a spasticity of scale 4 on modified Ashworth scale. On suspicion of atlantoaxial instability was confirmed after radiological investigation in form of dynamic X-rays and MRI cervical spine with craniovertebral joint instability was seen. Posterior atlantoaxial fixation and fusion was done, followed by physiotherapy. This was the first X-ray shown here was of 2017, for which patient was underwent THR in two stages. The last time patient came to us was 1 year back, for which for Lemaitre sign she used to complain of tingling sensations when she used to do a flexion of the neck, for which she was not able to be do day-to-day normal activities and had spasticity in both her legs. As soon as we did a surgical fixation and pedicle screw fixation of the cervical region and fixation of CV junction, the Lemaitre signs disappeared immediately following surgery. Intermittent stretching of hamstring was done by screen traction with 2 kgs of weight. Once full extension was achieved, it was maintained in extension brace. Full extension of bilateral knee was attained after 3 weeks and patient was mobilized out of bed with walker and brace. Last follow-up of 1 year, patient's spasticity has improved to scale 2 and is able to walk with stick. So the conclusion,
Vivesh, please wrap up.
Conclusion we got is C1, C2 instability was a part of CV junction anomaly in most common spinal manifestation in patient with spinal dysplasia leading to spastic quadriparesis. Screening of CV junction anomaly must be done in all patients with skeleton dysplasia. Thank you.
Okay, thanks, Dr. Vivesh. I welcome Dr. Amit Sharma as one of the panelists. Any questions?
Thank you, sir.
Dr. Amit, any questions?
No, I think it's a wonderful case report. And just a query that skeletal dysplasia, if they have seen furthermore skeletal dysplasias in their setup, so they have presented single case report. So they are advising to get a CT scan of every spine patient having such problems. So because either a craniovertebral junction anomaly to rule it out, we need to get a CT scan. So they are regularly doing CT scan of every patient now. This is the question.
No, sir, we are not doing regularly now. But if the patient comes with some kind of signs and symptoms, like if the patient is saying about weakness, progressive weaknesses, if he is having, or any kind of tingling or numbness sensation, then we suspect for CV joint instability. Otherwise, it comes economically. The patient, we didn't wanted to burden the patient. We do X-rays, but we have not seen such of good clinically. We can't prove that on just on X-rays the patient is having a CV joint instability. So we have not seen a lot of cases here. Maybe after this, I have seen only one more case.
Okay, thank you.
Okay, thanks, Dr. Vivesh.
Thank you.
Just one last question from me. Did you do any functional scoring for this patient post-operatively?
Sir,
or pre-operatively? Did you?
We just we did, sir, for spasticity we did modified Ashworth scale, and for operative management we did a Banks classification.
Okay, right. But I think the functional score would add to the credibility. Great. Thank you.
Thank you, Dr. Vivesh.
Okay,
we'll move on to Dr. Ankush Kundu now for his poster on autografts versus allografts in patients with benign bone tumors. Dr. Ankush, please stick to time. You can share your screen.
Good morning. My topic for poster presentation is autograft versus allograft in patients with benign bone tumor.
Okay, go ahead.
Okay, there are various ways of filling lytic bone defects. For example, autografts, allografts, and bone substitutes. Extended curettage is the treatment of choice for most benign lesions. To fill the defect after curettage remains a major problem, particularly in children and in large cavities. Autograft is a graft of tissue from one point to another of same individual's body and possess all essential properties. Allografts are easily available in various shapes and sizes, no donor site morbidity, and there is a potential risk of transmission. So our aim is to compare the results of autografts and allografts in patients with benign bone tumor and tumor-like conditions after curettage in view of healing of the lesions and complications, if any. This study was conducted in Pandit B.D. Sharma, PGIMS Rohtak. Total 120 patients of benign lytic bone tumors in extremities and amenable to curettage were included in this study. GCT and aneurysmal bone cyst were the most common type of tumors in our series. There were 24 patients of enchondroma and 11 patients of each of simple bone cyst and chondroblastoma. One patient had chondromyxoid fibroma. What we did, we made a large cortical window in the cavity for proper exposure. Extended curettage was done using the sharp curetages and high-speed burr. Defects after bone curettage was filled by autograft and allograft as per randomization. And then patients were evaluated clinically, radiologically at 3 weeks, 6 weeks, 3 months, 6 months, and 12 months. Autografts were used in 66 patients. Allografts were used in 54 patients. And what we found was autograft had shortest healing time with mean value of 7.21 plus minus 3.4 weeks with a range from 4 to 16 weeks. Allograft demonstrated maximum healing time with mean 13.45 plus minus 2.4 weeks with a range lying from 8 to 16 weeks. And the problem with autografts were additional scar in 100% patients, cosmetic deformity in 6.06 patients, recurrence in 6.06 patients, and infection in 3.03 patients. Serious discharge was observed in 53.7, and one patient had recurrence in patients of allograft. Functional assessment was done as per musculoskeletal tumor society rating scale. that is MSTS, while radiographic assessment of graft uptake was done as per Irwin grading. The overall average MSTS score was 26.75 with a range from 24 to 30. What we conclude is autograft is the best material to fill defect after extended curettage of benign lytic lesions of bone wherever possible, where allograft are the option if autograft not available, like in children or in large lytic cavities. This is the image showing 22-year female with enchondroma, and autograft was used in this case. And this is a 35-year female with GCT, and allograft was used in this patient. Thank you, sir.
Do we have any questions for Dr. Ankush?
Yes, sir. I have a question.
Please go ahead.
Dr. Ankush, can you please tell me that you are using extended curettage for simple bone cyst also? Well, usually
Yes.
that's not a usual conventional treatment for simple bone cyst or enchondroma. Usually a simple curettage is enough. Usually extended curettage is used for giant cell tumor. So is there any specific reason you are using extended curettage for such patients?
No, sir. But we were only seeing the result of extended curettage in this patient.
All right. I want to ask another question also, that you said that healing you have checked by radiological Irwin grading.
Yes,
So
sir.
how many, what is the landmark of resorption of the graft you take as a healing terminal point? Because you said autograft healed at around 7 weeks. So what is your terminal radiological point at which you decide that, okay, this is, we consider it as a healed?
Sir, the size of defect decreases with time.
Size of defect, I don't think it decreases with time. You have, there is a different grading system for it. I think if you could have put that in your study. Thank you. Thank you. Over to Dr. Samar.
Thank you, sir.
Dr. Samarth, over to you.
Dr. Ankush, please stop your screen sharing.
Dr. Ankush, please stop sharing your screen. Dr. Akshay, please be ready with your poster on accuracy of extrinsic landmarks and intrinsic vertebral markers in level identification in anterior cervical spine surgery for traumatic subaxial cervical spine injury. Please share your screen, Dr. Akshay.
Is Dr. Akshay here? I can't see him.
Dr. Hardik, are you here?
Yes, sir.
Please go ahead with your presentation.
Yes, sir. Good morning, everyone. I will be presenting a poster on dyskeratosis congenita, a case of bilateral, with the case of bilateral AVN femoral head, a case report. Introduction. Dyskeratosis congenita is a rare hereditary disease which was first described by Zinsser in 1906. It is also known as Zinsser-Cole-Eggman syndrome. Dyskeratosis congenita occurs mostly in males and clinically manifests between 5 to 12 years. A classical triad of skin pigmentation, nail dystrophy, and oral leukoplakia occurs within complete expression of this syndrome. It is a fatal condition in which the majority of the patients develops aplastic anemia and malignant transformation occurs in keratotic white patches. Dyskeratosis congenita is a clinically heterogeneous inherited bone marrow failure syndrome. Apart from the clinical triad, additional features like epiphora, premature gray hair, developmental delay, microcephaly, pulmonary fibrosis, avascular necrosis of shoulder and hip, and leukemias are seen with this syndrome. This is a case report of 22-year-old man presented to a orthopedic OPD with debilitating pain in the left hip since 7 months. resulting in a limping and ambulating with a wheelchair. He was a software programmer and was out of work in the view of his left hip. He had a traumatic right femoral fracture for which fixation was done with the intramedullary nail 6 years back and has united. He had no history of addictions. He had a history of hepatitis 4 years back and was managed symptomatically. He was having asymptomatic brown pigmentation all over the body, predominantly over chest, trunks, and arm and thigh since birth, changes in the oral mucosa, and change in the nail morphology since 8 years of age. General examination shows fine reticulate gray brown pigmentation over chest, abdomen, arm, and back. There was micrognathia and dystrophy in all the nails. Leukoplakia was presented in the oral cavity, forming an irregular blackish patches on the buccal mucosa and tongue. Here are the pictures. In figure 1, I'm showing the fine reticulate gray-brown pigmentation over the front of the chest. In figure 2, it's a preoperative X-ray pelvis in both hips showing osteonecrosis of the hip, in which the left is more than right. In figure 3, we are showing the dystrophy of the nail toes. In figure 4, there's a skin histopathology which shows the epidermal atrophy and the focal vacuolation of the basal layer. In figure 5, we are showing the dystrophy of nails, and in figure 6, we are showing oral leukoplakia. The examination of the hip revealed the tenderness in both the hip with fixed flexion deformity of 30° in left hip and painful abduction and internal rotation with 5 centimeters limb discrepancy. Right hip has also had a fixed flexion deformity of 15° with the painful movement, and the X-ray of the pelvis of both hip revealed the AVN of femoral head. Discussion. Dyskeratosis congenita is reported to be a fatal condition. There are X-linked autosomal dominant and recessive forms of DC. It mainly occurs in males, inherited as an X-linked recessive disorder with male to female predeletion of 13:1. In this case report, biopsy was not suggestive of any malignant changes. It just revealed markedly thinned out epidermis, exhibiting orthokeratosis, complete flattening of the retipex, and our patient was presented with the pain, avian-induced arthritis of the left hip, which was managed successfully with the left hip replacement. And fortunately, he has done remarkably well after 2 years of his diagnosis without any bone marrow function and has not shown any dermatological worsening. A conclusion, our case report with probably the most benign presentation of this rare and serious disorder to be reported in the medical literature. The unique feature of this case were the presentation of the major orthopedic problem, skin manifestation with no gingival or hematopoiesis problem. We want to highlight the unusual manifestation of the syndrome and recommend close multidisciplinary follow-up of such cases for the progression of the malignancy of the blood through regular blood count and skin and bone marrow biopsies as necessary. Acknowledgement. Authors reported no conflict of interest and no funding was received for this work. Thank you.
Thank you, Dr. Hardik. Dr. Amit, any questions from your side? Dr. Hardik.
Dr. Hardik, you say in your first slide itself that it is known to have AVN of shoulders and hip and leukemia in these patients. So what is rare about your case? If it is a known case in DC that AVN of hip can happen.
Sir, it is a rare presentation, sir. The dyskeratosis congenita itself is a rare condition in which the AVN of the hip was shown in my case.
What is rare in terms of the orthopedic presentation here? Because we are talking about orthopedics here.
Yes, sir.
I understand DC is a rare condition, but DC is known to have AVN of hip and shoulders, and I'm sure we all know that AVN of hip, the treatment of choice would be a total hip replacement. So what is rare in your case? I get a case of DC with AVN of hips. We all know that we would go in for a total hip replacement. What is rare in your case?
Sir, the skin manifestation overall with the AVN is rare, sir. I have not seen any other case with the skin manifestations and AVN of the same with dyskeratosis.
Probably the skin people or the medicine people will be more experienced to comment on this, because patients who come to you with DC will only be the ones who have AVN of hip or shoulders. For people unrelated with hip and shoulder condition, they would never come to you.
Yes, sir, but we would generally ignore these cases, sir, just because we just follow the we will just go for the hip treatment, and we might miss the skin manifestation also, and that is what the case is about, sir. Just if we will try to diagnose it on the early stages, we will be saving a patient from a major malignancies or something like that.
Okay, thank you. So thank you for your presentation, Dr. Hardik. Now I invite Dr. Anoop for his presentation on functional outcomes in a series of 50 supracondylar fracture humerus managed with the cross pinning and lateral pinning. Please stick to time. Your 3 minutes start as soon as you start sharing.
Just
Dr.
to
Anoop, are
add,
you
Dr.
here?
Rabindro is here with us as a panelist, but his mic is not working, but he's here judging the presenters. Thank you, Dr. Rabindro.
Dr. Anoop, are you here? Dr. Sagar, please go ahead with your presentation, current experience of augmented reality applications in orthopedic patients.
This should be an interesting talk.
Dr. Sagar, we are unable to hear you.
Okay.
We can see your slides, but we are unable to hear you, Dr. Sagar.
Hello, can you hear me now, sir?
Yes.
Yeah.
Am I audible, sir? Yes, sir. Good morning, everyone. My name is Sagar Bagwe, and my topic for today is current experience of augmented reality applications in orthopedic patients. The purpose of AR in orthopedics is to increase the surgical ability by intuitive augmentation of medical information. Um, Augmented reality uses special hardware and software to provide the surgeon with the ability to merge real life objects with computer generated images in real time. Orthopedic procedures with AR applications presently include spine, tumor resection, fracture fixation, arthroscopy, and total joint arthroplasty component alignment. Surgical procedures in orthopedics frequently use medical images both pre and intraoperatively, as illustrated on the images at the on the right. But and also include mechanical steps such as resection or implant insertions. Thus, AR will have many applications here. The aim of this study was to summarize the current state of application of AR in orthopedics at the clinical level and provide a perspective on the future potential of AR. A systematic review was conducted in which three databases were searched using the following keywords up to 12th November 2020. A total of 326 studies were identified, and using the following inclusion criteria, such as studies in English language, minimum level 4 and above of evidence, and AR used in musculoskeletal surgery, including patients. The exclusion criteria used in the study were review articles, oral presentations, case reports, animal trials, and in vitro studies, non-English German articles, and AR used outside of musculoskeletal surgery. Using the Prisma guidelines, the identified 326 records were screened, and finally 11 full text articles were chosen for final review. The following graph shows a clear uptrend of AR studies in the patients over the last decade, with 5 of the 11 selected studies happening in the last year itself. The 11 full text articles were reviewed and further categorized on the basis of authors, specialty, number of cases in each study, year of the study, origin, country of origin of the study, and the head mounted device or other such device used. Most of the studies, as you can see, used custom designed devices, head mounted devices such as Microsoft HoloLens, CAMC by Siemens, Epson, Google Glass. Only 3 of the 11 used simple devices such as depth camera or a smartphone camera. Specialty wise, most 6 of the 11 studies were conducted in spine. Uh, Country wise, most of the studies happened in Southeast Asian countries such as Taiwan, Japan, and China, with a few studies being conducted in Germany as well. Conclusion: being applied mainly in complicated fields such as spine and arthroplasty. All studies used custom designed AR systems, so the technique is still heavily reliant on engineering professionals. The studies need to compare AR techniques with conventional methods. More clinical studies required to validate the AR techniques right now. And AR has a great scope for further exploration in orthopedics. Thank you.
Thanks, Dr. Sagar. So what did you learn personally from this study? Are you using any AR, or are you looking to do that?
Yes, so we are conducting in our college about 3 clinical AR studies right now. We were searching through the literature, and finally, sir came with an idea that we should try and even tabulate these findings. That AR needs to be more. There needs to be more awareness regarding this technology of AR.
Okay, thank you. Any questions from Dr. Sagar?
So I just have one query. So can you just elaborate that if you are going to use AR in total arthroplasty, how it is going to work?
Yes, sir.
Yeah.
In one of these studies, a smartphone camera was used. As you can see in this picture, a smartphone camera was used, and in which an app was loaded. The app identified a specific identifying point. I mean, specific landmarks on the acetabular cup, and through the smartphone, the app, when the smartphone was superimposed on the patient's here, it directed the placement of the component, or the hip component itself on the hip.
All right. Okay. Thank you.
Yes.
Thank you, Dr. Sagar. We move on to Dr. Kulbhushan Kamboj for his presentation on GCT of distal fibula.
Yes, sir. Am I audible?
Yes, you are.
Yes.
So my poster is on GCT of distal fibula. Its management as en bloc resection and reconstruction with ipsilateral fibula, a case report. So as we all know, GCT is a benign but aggressive lesion, and there are distal femur, proximal tibia, and distal radius are the common sites, and distal fibula is a very rare site, and it is rarely reported in literature. We encountered a case and presenting that case and presenting its management. It's a 33-year-old male present with a swelling in distal leg and ankle. On examination, swelling was of 4 and 2 centimeter in size on lateral aspect of leg and in continuation with the fibula. We go ahead with investigations. X-ray has a lytic lesion of approximately 4 and 2 centimeter in size in left distal fibula up to the malleolus. Zone of transition was narrow. There was thinning of the cortex and there was a cortical breach. Similar was the finding on MRI. As we can see in this picture, there was a lytic lesion biopsy, needle biopsy, which confirmed it is a GCT. Now the surgical part. We go ahead with the surgery under spinal anesthesia. Direct lateral approach to fibula was used, and en bloc excision with safe surgical margin was done. The reconstruction of the distal fibula was done with this ipsilateral fibula, and it was fixed with 1/3 fibula, 1/3 tubular plate. This was the en bloc excision. This is the immediate post-op X-rays, and on the X on the right side it's at 3-month follow-up. We can see that the ankle is stable here. Post-op operatively, at 2 weeks, the stitches were removed. Partial weight bearing was allowed after 2 months, and patient was able to weight bear at 6 months without any complaints. These are the. There was no full range of motion, and there is no weakness of the foot. This is the video at 6 months follow-up. we can see that there is no complaints. Patient has normal walk. Discussion. GCT can be managed surgically in different ways, but when there is a thinning of the cortex and there is a cortical breach, so extended curettage, which is most commonly performed, is not possible and is not a good choice. So the treatment options left were en-bloc excision with primary ankle arthrodesis or en-bloc excision with reconstruction with a graft. We chose en-bloc resection with ipsilateral fibular graft as patient was a young patient. So in conclusion, we found en-bloc resection with reconstruction of the reconstruction with ipsilateral proximal fibular graft is a reasonable salvage option when the distal fibular GCT can't be curettaged normally. Thank you.
Thank you, Dr. Kulbhushan. Certainly an excellent result for your patient, considering he had a difficult tumor in the distal part of his fibula. Any questions, Maninder sir or Dr. Amit?
Dr. Kulbhushan, I think definitely a very good, result that you've achieved. Was there any instability? You fixed the syndesmosis. Did you find that the ankle was unstable because he lost all the lateral ligaments? Did you need to reconstruct any of that, or did you have any instability of the lateral side afterwards?
Intraoperatively, we found there was instability, so we fixed it with the syndesmotic screw. Post-operatively, at 6-month follow-up, initially we expected there will be instability, so we didn't recommended the screw removal at 3 months, as usually in trauma cases we advises.
Sure.
So we continued with this, and patient has no instability with the syndesmotic screw as of now, because there is a limited follow-up of around 8 months as of now. So patient
did you repair the lateral ligaments as well?
We were not no, we were not able to, because we had resected the soft tissue extensively, so it was not.
But he didn't have any instability later on. Yeah. Okay. Great. Thank you. Anything, Dr. Amit?
No, I think thank you, sir. It's a wonderful presentation. Thank you.
Dr. Kulbhushan. Can you stop your screen sharing? Yeah.
Thank you, Dr. Kulbhushan. Now we have Dr. Akshay Raj presenting on accuracy of extrinsic landmarks and intrinsic vertebral markers in anterior cervical spine. Dr. Akshay.
Yes, sir. Yes, sir. I'm sharing my screen right now. Sharing my screen right now. Just a second.
Are you down with COVID?
No, sir. I had to report to duty, and there was a sort of a difficulty in getting to the place on time with the conference and also. That's why I couldn't show up.
The only reason I asked you is because I see a manifold point right behind you.
Yeah, no, sir. I am in the hospital right now.
Okay. Go ahead.
Yes. Good morning, and sorry for being a bit late. So I'm here to present my poster on the accuracy of extrinsic landmarks and intrinsic vertebral markers in level identification in anterior cervical spine surgery for subaxial cervical spine trauma. So to get things rolling, in patients usually undergo anterior cervical spine surgery in subaxial cervical spine injuries, because they are very straightforward and they're basically the workhorse approach for the cervical spine, and they have consistently good results with very less complications. And classically, it's been taught anatomical landmarks like your angle of mandible, hyoid bone, and thyroid and cricoid cartilage help in level identification, but the foolproof way to reach the operative level is your C-arm. But we have found in developing countries like India, there is very limited access to the imaging equipment. So there is, we thought we'll undertake this study to develop a technique for such situations. So we basically used a preoperatively done marker X-ray on the day of surgery with markers placed on the angle of mandible, the hyoid bone, the thyroid cartilage and cricoid cartilage, palpated by 2 surgeons, taken just before the surgery, and then the patient was shifted to the OT. This position mimicked the position that the patient was in intraoperatively. So this guided the skin incision placement. Secondly, preoperatively taken CT and MRI, the mid-sagittal sections especially, showed morphological changes related to the injury. These were used to identify the level intraoperatively by palpation and inspection. These were classified as bony lesions, step-offs in fracture dislocations, and soft tissue injuries like disc injuries, annular ruptures, and antilongitudinal ligament injuries. So we found that the angle of mandible corresponded to C2 in 95% of patients almost, and the rest of the markers, the hyoid, thyroid, and cricoid, which are classically taught at C3, C4, and C5, C6 disc respectively, showed wide variations with respect to the patient's body habitus, BMI, sex, and age. So the method that we have elucidated in our study was gave us an accuracy of around 83% of correct vertebral level identification, which was verified by a C-arm intraoperatively before level identification was done, following which the surgery was proceeded with. We found that bony markers like your teardrop fractures and other burst fractures, etc., and the step-offs between fracture dislocation levels were significantly easier to identify with a very less error rate, as you can see. The soft tissue markers like the injury of ALL and intervertebral disc the surgeons had significant inter-observer disagreement in level identification, which ended up being as long level identification, which needed to be corrected after the C-arm shot was taken in a significant number of patients. So we found that your bony markers and step-offs are a good predictor of correct level identification. So this shows the whole surgery. This particular case shows a rupture of the annulus and the anterior longitudinal ligament, which was identified intraoperatively. Needle was hammered into the vertebra to be operated on, and then a discectomy was done. A tricortical iliac crest graft was placed, and your traditional anterior-cervical locking plate was done. So postoperatively, most of our patients showed good recovery, except in incomplete lesions, which comprised around 44 patients out of the 70 patients that we operated. Of them, only 42 patients remained grade A. Of the incomplete lesions, we had a recovery of around 70%, which is in keeping with other similar studies. For example, Isla et al. From 2004 had a similar recovery rate. So we conclude by saying that the technique that we have developed, which can give you consistently reproducible results if followed step by step with the proper preoperative marker X-ray, which is done specifically to eliminate the changes of the anatomical landmarks with respect to neck position and patient habitus. And this should give a modality to operate subaxial cervical spine trauma in limited resource settings. Thank you, sir.
Thank you, Dr. Akshay. Any questions, Dr. Amit?
I was just wondering that I just want to ask that the extrinsic markers
Yes,
which you used or you also ought to use,
yes, sir.
have you also checked the reliability factors of those markers? Because in results you didn't mention about the extrinsic marker.
Yes, sir. We basically found we thought that we'll just study the correlation with respect to previous studies, and we found that this correlates well with previous studies also. The angle of mandible has been consistently reported to be the only reliable marker. The rest of the hyoid bone all move along with your ligamentous attachments. The hyoid bone, the cricoid cartilage, and thyroid cartilage, especially the thyroid cartilage, varies very much with male and female sex also. It is found to be at a higher position in females and slightly lower in males. A study by Ali Mirjalili et al. From 2008, if I'm not wrong, also bore out our results that we got. So I couldn't find space in my poster to put all the comparisons that we did. And so we thought by doing a marker X-ray on the day of surgery, by stimulating the intraoperative position, we'll eliminate the variability that is associated with your extrinsic markers, because subaxial spine, you will not be using the angle of mandible most of the time. You are using
how often accurate you found the marker X-ray?
Sir, the marker X-ray, we did. This was my time. So I and one of the senior residents, both of us who were supposed to go to the OT, went and we got it done in front of us, positioning the patient. Then when we went along with the patient, we did the intraoperative positioning. So this was a laborious task. We had to go, we had to get it done. Then we had to shift the patient to OTs
Actually, I
just to make
think,
sure.
Dr. Akshay, you didn't get my question. I'm
Yes,
asking
sir.
that marker X-ray is a common thing which we usually get it done in a spine patient.
Yes, sir. Yes, sir.
So how you are marking the skin and how accurate you are finding the marker X-ray as far as your internal bony landmarks are
Yes,
concerned?
sir. Yes, sir. We just use the marker X-rays for skin incision placement, considering the traditional levels that are elucidated. And बाद में we found how much it correlated. Sir.
That is what I'm asking. That marker X-ray, how you are marking over the skin with the marker? What you are using to mark the
Okay,
X-ray?
sir. We used you have the pins, right, sir? We used the cap of the pin. That was radio pin.
So when
We
you remove,
palpated it.
and then when you remove the pin during
Yes, sir. We use just before painting and draping, we used a permanent marker on the skin that doesn't rub off after the skin preparation is done.
so any infection?
No, sir. None of our patients had any surgical site infection, and most of the all of the wounds healed uneventfully.
Because this is a common thing which we had also encountered
Yes, sir.
most of
Yes,
the
sir.
time, and even the permanent marker when we do a good cleaning draping
Yes,
gets
sir.
rubbed off.
Yes, sir. Yes, sir.
So in our institute we usually used mehendi as a marker for it.
And so initially we had that problem. We also, for the later cases, what we did was we did initial cases we did a small scratch with the needle, but that sort of gave us more of a worry of infection. So that's why we ended up using permanent markers in the later
Do you
cases.
find that extrinsic marker film equally reliable like the intrinsic bony landmarks, or?
No, sir. As far as the study shows us that you can't rely on just the extrinsic markers alone. That the extrinsic markers is basically just, the marker X-ray basically eliminates your variability with respect to the position. That on itself will be inadequate. You will need the intrinsic markers to reliably say the reliability to arrive at the operative level.
Thank you.
Dr. Akshay,
Yes, sir.
my question to you is I'm unable to comprehend your conclusion that
Yes,
how
sir.
this thing will work in a resource limited setting. You
Yes, sir.
yourself, this is very laborious. Instead of going down on the resources, in fact, it is using up 2 residents in early in the morning before surgery, taking the patient with a fracture probably to the X-ray room, giving him a radiation just prior to surgery,
Yes, sir.
and then shifting the patient back. So how does it
Yes,
help
sir.
in a resource restricted setting? I think this is increasing the resources rather than decreasing the resources.
Yes, sir. I get your point, sir. But the thing is, most of the places that were reported from the studies where the resources are limited, करके जो जहाँ बता रहे हैं, they usually have a portable X-ray machine. So if rather than getting a C-arm, they can just use a portable X-ray machine to get one shot, just to confirm the level and then proceed with the surgery. That was basically the idea of the technique, sir.
How is this helping the patient in any way? That is my question. So, are you suggesting that we
Sir,
start doing
yes, sir.
cervical
Yes, sir.
spine surgeries without the use of a C-arm intraoperatively?
No, sir, that is not what we are suggesting. But if at all, if this is basically to reduce the load on the healthcare system, where patients do get end up in, for example, in our hospital, we got patients who were not operated for 2 months, 3 months, and then they are just coming here. They are coming here just for rehabilitation. So rather than letting that happen, they can be operated in a peripheral center where they won't have access to equipment as like we have in the tertiary care setup. That was the idea.
So, with regards to equipment, do you only mean a C-arm intraoperatively?
Yes, sir, just the C-arm. But a portable X-ray machine is usually available in a hospital where orthopedic surgical practices are going
So
on.
I think we are sending a wrong message across by this paper. I don't think a spine surgery, especially a cervical spine surgery, should be done at a peripheral center where there is no access to an intraoperative C-arm. A lot more things than just the level of identification can go wrong in doing a cervical spine surgery.
Yes, sir. Yes, sir.
Look at a lot of things intraoperatively, and I don't agree that this will decrease the resources, utilization of resources. In fact, this is resource heavy. It requires a preoperative X-ray. First case in the morning, you might need an X-ray for this patient at 7 a.m. And most
Yes,
of the
sir.
radiology departments don't open at 7 a.m. across. And we are unnecessarily exposing the patient to more radiation early in the morning. We are increasing the shifts between the patient from the bed to the trolley to the X-ray room, then X-ray there, and then shifting him back to the OR. And then in the end, we should not take home a message that it is okay to do a cervical
Hello?
spine surgery without an intraoperative C-arm.
Yes, sir. Yes, sir. So I
I
get
agree to Dr. Samar.
yes.
I think we can conclude here. We've had a great discussion, but I think yes, we got the point that, as Dr. Amit, Dr. Samar said, that, it may be the overall theme of the study is to reduce the work required, or to be able to do it in a more peripheral setup. But we should not be doing it without essential equipment such as this C-arm. I think that's really important.
Yes, sir, I get the concept, but our study, we did not have any revision surgery for malpositioned implants or anything like that. It was all of the 70 cases were followed up for the next 6 months, after which they were handed over to rehabilitation departments.
And they were not, C-arm was not used intraoperatively for these cases.
Sir, we use CM just to confirm if we've arrived at the proper level or not, sir. It was just 1 or 2 shots. After the dissection was done, we used 1 2 shots to confirm the level, after which surgery was proceeded, sir.
So that's again an important step, isn't it?
Yes.
And if you are doing that step anyways, then we are not
Yeah.
helping the marker preoperatively. If you have a C-arm inside and you're checking it anyways, then
Yes,
might
sir.
as well just take another C-arm shot just prior to draping or after draping.
Yes, sir.
That will save a lot of time
Yes,
and
sir.
resources. Anyways, thank you. Thank
Great,
you,
great.
Dr.
I think we
Akshay.
should conclude here.
Yes.
Thank you.
Thank you.
Thank you, Dr. Akshay. I think overall a good study. Slightly, methodology should have been slightly better. Great.
Yes.
Thank you.
Thank
Do
you,
we
sir.
have Dr. Anas here?
Yes, sir.
Yeah, please go ahead with your presentation on humeral arthrodesis in a case of GCT.
Good morning, everyone. Today's topic post-operation is humeral ulnar arthrodesis in the case of giant cell tumor involving distal humerus with radial nerve entrapment. Giant cell tumor of bone account for 4% to 5% of primary bone tumor and 20% of the benign bone tumor. GCT of bone is usually solitary and benign, but locally aggressive with 5% of metastasis and 1% to 3% of malignant transformation. GCT of bone commonly occur at the distal femur, proximal tibia, distal radius, proximal humerus. It occurs at the distal humerus is rare. Case profile: 35-year-old male patient present with pain and swelling of left elbow, tenderness and swelling on the posterolateral aspect of the elbow, more prominently over lateral epicondyle of humerus. Radiography suggests to expansile osteolytic lesion with a cortical breach on the lateral epicondyle, suggestive of the pathological fracture. Patient was initially planned for extended curettage, but patient refused and again presented after 1 year with poor skin condition and increased swelling and joint involvement with radial nerve entrapment and tumor. Management. We done segmental resection of the lower arm with the tumor, and upper forearm was done. Tumor was completely excised and humeral ulnar arthrodesis was done. Radial nerve resected with tumor from margin and raised nerve structure preserved. Patient is asymptomatic after 2 years. Follow up with no recurrent and good hand function. Discussion. Through GCT is a benign bone tumor. It breaches the cortex and invades the soft tissue. MRI is useful to assess extracortical spread and intramural extension. Surgery is the treatment of choice. Curettage is usually combined with cementing or bone grafting or both. Through endoprosthetic reconstruction of elbow joint is usually done in case of distal humerus GCT. Nowadays, in our case, humeral ulnar arthrodesis was preferred in view of massive size of tumor and radial nerve involvement and economic status of the patient. GCT of the bone is benign condition usually seen in long bone, while involvement of distal humerus is very rare. During surgery, always a trial for limb salvage should be given, particularly in case of the benign tumor. Thank you.
All right. So, Dr. Anas,
yes,
good case report. I have a question for you.
Okay.
that first of all, you are saying that giant cell tumor is a benign tumor.
Yes, sir.
I just want to raise a query that it can be malignant also,
Yes,
as
sir.
you mentioned in introduction. So, had you performed anything to rule it out that it is not malignant? Because if it is a malignant tumor, maybe the procedure of limb salvage which you are doing or proceeding ahead, your idea would have changed. So, what you have done to rule out malignancy of this giant cell tumor?
Yes, sir. We checked for any pulmonary involvement in the GCT, but there was no any symptom of pulmonary involvement. The patient was not willing for PET scan or anything else because of the.
It is not about pulmonary involvement. I'm not talking about metastasis. I'm asking about, did you repeat the biopsy before planning for the humeral arthrodesis? Because the patient presented to you earlier. I
Yes.
hope you have done a biopsy then,
Yes, sir.
and then you have repeat the biopsy also.
Yes, sir.
Repeated the biopsy.
After excision, we have done biopsy again.
I'm not asking after excision, sir. I'm asking just before planning humeral arthrodesis. Did you repeat the biopsy also? Because you have not
No,
mentioned.
no, sir.
That is what I'm asking, that it should be an important step, because your management would have changed if a repeat biopsy would have shown signs of malignancy as far as this such a huge tumor is concerned, and maybe your decision towards limb salvage may be altered. This is my opinion. So if you are seeing such a huge tumor, so you might have gone for a repeat biopsy
Repeat
also in
biopsy.
such cases.
Yes.
All right. So Dr. Samarth and Dr. Maninder.
Thank you. I think if there's no other questions, we can move on to the next presentation. Thank you, Dr. Anas.
Thank you, sir.
We had Dr. Sandesh in the last session who missed out his presentation due to some issues. So if he's available now, can we go ahead for his presentation?
Sir, this is my poster presentation, sir. So can you see my presentation,
For what?
sir?
For tearing? Okay.
So can you see my presentation, sir?
Yes, we can.
Yeah. Okay, sir. So this is a case report. It's a recurrent synovial chondromatosis, a REC case report. Coming to introduction, synovial chondromatosis is a proliferative disease of unknown etiology, results in osteocartilaginous metaplasia of synovial epithelium, leading to formation of cartilaginous nodules or loose bodies within joint, bursa, and tendon sheath. It occurs most commonly in 5th decade of life, with predilection for rare and present before the age of 20. It is a rare benign disease. Its true incidence is unknown. However, worldwide reported incidence is about 1.8 per million population per year. In my case report, it was a 28-year-old male presenting with chronic progressive pain and swelling in the left knee over a period of 3 years and 2 months. Symptoms were exaggerated when the patient climbed stairs. On examination, there was no local rise of temperature, tenderness present over the medial joint line and lateral joint line, with thickening of the synovium noted over the medial joint line of left knee, with range of movements of knee, that is flexion of 0 to 70 degrees and further terminally painful. The patient underwent radiograph of left knee showing multiple loose bodies in the left knee joint. This patient actually is a case of recurrent synovial chondromatosis. He had similar complaints 10 years back, for which he was taken up for arthroscopic debridement, and following which, after 10 years, he presented with recurrent symptoms. This time, we operated with the open procedure. We went with the paramedian patellar open procedure. We did partial synovectomy and excised all the loose bodies. These are the surgical images showing the loose bodies present in the knee. Post-operatively, patient was stable and he was having a in the past 1 year. Conclusion, synovial chondromatosis is a rare condition which can be highly aggressive and destructive. This case highlights the importance of careful clinical assessment and late thickening, appropriate use of investigations, and careful preoperative planning of the case. The peculiarities of this case are its age of presentation and metaplastic changes at the margins of joint. And these are my references, sir.
Sir, can you hear me?
Yes, we can. Thank you, Dr. Sandesh.
In this case, since 1 year, we have been following up the case. Patient is totally fine. He's having good range of motion, and he doesn't complain of any such repeated complaints. And in case the patient presents to us and further with the same complaints, we are planning on a radiotherapy for him, sir. The case is rare because the first episode of his presentation was at the age of 19 years when he had a similar complaint. He had a similar complaint of restricted knee movements with the pain in the left knee when he was investigated and found to be a case of synovial chondromatosis, and he was taken up for arthroscopic debridement, following which 10 years later again he presented to us today with the same history. When we investigated, it was again a recurrent synovial chondromatosis, for which we did an open partial synovectomy and excluded all the loose bodies. Now the patient is doing fine.
Okay.
And
Any question?
After repeat debridement, Dr. Sandesh, what is the radiotherapy protocol you followed?
So we just went with the plain X-ray and MRI, sir.
I'm asking about radiotherapy protocol.
So we have not given any radiotherapy as of now, sir. We have not given. It is the next time if the patient presents to us, we are planning on radiotherapy, sir.
All right. In my opinion, your case is a basic simple one, which is quite common, but though the age is a bit younger in which you found the patient.
That is the only reason. The age of presentation was very early, sir. That's why we presented the case.
Thank you. Thank you. Any other question, Dr. Maninder? Dr. Samad, over to you.
No, thank you. Thank you, Dr. Amit. Thank you, Dr. Sandesh.
You,
you can go to your OT now. We have the next presentation from Dr. Raviraj. Do we have Dr. Raviraj here? Dr. Ravi, are you here? So we will move on to the next. Dr. Rahul, are you here? Dr. Rahul is here. His presentation is on rapid destruction of the humeral head due to mobility and management by prosthetic surgery, a case report. Please go ahead.
Yes, sir. Good morning, judges and my dear colleagues. I am presenting my poster titled as Rapid Destruction. Rapid destruction of humeral head due to bone fragility and management by prosthetic surgery. Going to the introduction, rapidly destructive arthritis is a marked destruction of a joint within months of onset of symptoms. This condition usually involves the hip, with shoulder involvement being very rare. Subchondral insufficiency fractures are considered to cause several femoral head collapse associated with hip RDM. However, the pathogenesis in shoulder remains very unclear. Here we present a case of shoulder rapid destructive arthritis involving different joint destruction pattern, which were probably due to insufficiency fracture. The patient was informed that her details would be taken for publication or any case report. Presenting this case, it was a 46-year-old female presented in the outpatient department with complaints of pain and restriction of movements at left shoulder joint since 3 months. Pain was insidious in onset and gradually progressed over the months of 3 months from a VAS score of 3 to a VAS score of 7. Going to the clinical findings, shoulder contour was totally lost. The local temperature was normal. There was generalized tenderness over the shoulder joint. The degree, extension 20 degree, internal rotation was 20 degree, external rotation was 0, and the circulation was intact, and there was a minimal hypoesthesia on the lateral aspect. Then we evaluated the patient, her X-rays and MRI. In the X-ray and MRI, you can clearly see there was a total erosion of the shoulder joint. Then we took this patient for surgery. Anesthesia. First, the shoulder joint was aspirated. A 10 ml of reddish fluid was aspirated. A deltopectoral approach was taken. The capsule was dissected, and we found the anterior border of the glenoid was completely eroded. There was hypertrophied synovium, and we found fibrous tissue curated out. As you can see in the image, 1 centimeter of rice body was also found there. Then we made a prosthesis. Now this prosthesis was made with a EDTA bulb, in which we put a reconstruction plate. We bent that reconstruction plate, and this construct was coated with antibiotic and bone cement. Then we implanted this prosthesis as a in the place of the humeral head as a prostalac. Now coming to the discussion. There have been 2 studies similar to this. In one study, there was 60 cases of rapid destructive arthritis of shoulder. That now most cases were elderly women, and this condition was characterized by presence of large amount of synovial fluid. The case we report here apparently showed similar characteristics. A differential diagnosis of our cases include osteonecrosis of the femoral head, rheumatoid arthritis, pyogenic arthritis, crystal-induced arthritis, hemodialysis-related destructive arthropathy, osteoarthritis, steroid-induced arthropathy, and cuff tear arthropathy. In imaging studies, our case showed significant destruction in the humeral head on X-ray and a lower intensity area beneath the surface of humeral head on MRI. There was another study which reported a case of rapid destructive arthrosis of shoulder, in which reactive new bone formation consistent with fracture callus was seen in the humeral head. We concluded that bone destruction in their case resulted from subchondral insufficiency fractures due to osteoporosis. This condition could favorably be compared with rapidly destructive arthritis of hip joint, in which subchondral insufficiency fractures have been described as a cause of rapid joint destruction. Thus, we conclude that humeral head destruction does occur as a result of insufficiency fracture in women. To conclude, we present a case of shoulder RDA demonstrating a destructive pattern. Although shoulder RDA is a rare condition, this disease should be included in the differential diagnosis of acute onset shoulder pain in female patient with osteoporosis and persistent joint effusion. Thank you, sir.
Thank you, Dr. Rahul.
Yes.
So, any questions for Dr. Rahul?
Yeah, I have a question. Dr. Rahul,
yes.
You have not kept the photograph of clinical outcome. So can you please tell what was the clinical outcome after putting this prostalac, and what was the reason not to put prosthesis in such cases?
Sir, sir, this patient was not. Our hospital is in the rural area, so the patient was not affording. So to give her some movement for time being, we planned this surgery for her.
Okay, so it would be a good idea that you have included the photograph or clinical photograph also, so that we can
yes, sir,
get a
yes,
message that after putting a prostalac also, we can get this much amount of recovery. So what is the follow-up? How many months old follow-up you have for this patient, and what is the clinical outcome? Can you tell me right now?
Sir, we had a follow-up for 6 months.
Right.
Her external rotation and internal rotation was improved, but the abduction, we were not able to get her full abduction. The abduction was the same as the pre-op.
How you are managing external and internal rotation also, because in your prostalac area, I could not able to see the GT and LT. So have you tied them back to the prostalac? Have you created some holes in the prostalac? How you manage to achieve that external or internal rotation? Because the GT and LT is missing from the X-ray. That's why I'm asking. Post-op X-ray. Yeah.
Sir, post-operatively, as compared to the pre-op movements, the post-operatively the patient had she was able to do her daily course at home. So whenever she came to the OPD after the for follow-up period, we saw there was a recovery in the internal rotation and external rotation. We
Dr.
didn't
Rahul,
do any modification.
sorry
Yes,
to
sir.
interrupt you. I think you misunderstood my question. I'm asking biomechanical reason of getting better external or internal rotation when the GT and LT is missing from the post-op X-ray and you have not tied them somewhere. So how this patient can get a better function result? That is what I'm asking.
Sir,
Thank you. Any other questions, sir? Dr. Maninder, Dr.
No, I think I missed part
I
of the
think
presentation, so sorry. Yeah.
I think he has improved the motion because the pain of the patient might have gone down. That is the only possible reason that the passive movements might have increased.
Yeah, passive movement might have increased, but active movements, that is what I'm asking. What is the result outcome? But he has not mentioned specifically about that. So I
Have you
raised the
used
question.
any outcome score like a Oxford shoulder score or some?
No, sir. No, sir.
So shoulder score should always be used when you are
Yeah,
doing a
okay,
surgery
sir.
around the
Yes, sir.
shoulder,
Yeah.
because clinical outcomes in terms of functional outcomes are very important in evaluation of these patients. If you say they are able to do their daily living and activities, it does not mean even patients with
Yeah.
shoulder arthrodesis are able to do most of their daily living. So that is not a good way to present your movements in the shoulder or the
Yes,
functional
sir.
outcome. You
Yes,
should
sir.
use a functional score whenever you are
Yes,
doing
sir.
a study.
Okay, sir.
Okay, overall a nice presentation. Thank you.
Thank you, sir.
We can move ahead to the next. Dr.
Yeah,
Samat,
thank
over
you.
to you. Yeah, doctor.
Can you stop sharing your screen, Dr. Rahul?
Do we have
And
Dr.
can we
Ravi
invite
Raj? Is Dr. Ravi Raj here now?
Raviraj Solanki? No, I
he's still
can't
not
see
here.
him on the. So I think we can invite Dr. Narottam Das for his presentation.
Yes, sir.
On the outcome of arthroscopy fixation of acute AC joint dislocation. Das, please start sharing your screen.
Sir, just a second, sir. Sir, can I present next? I am having some trouble in sharing the screen, sir.
Hello.
Hello, sir. Sir, I'm having trouble with sharing the screen. Can I present next?
That's fine, Dr. Narottam. Yeah, we can take it next on. So is Dr. Shiv Shankar Yadav here? Dr. Shiv Shankar is not here. Then Dr. Soda Varapu Praveen.
Hello. Hello.
Yeah, Dr. Praveen, you're there?
Yes,
Okay.
sir. Yes, sir.
So will you be presenting on floating elbow injury?
Yes, sir.
Okay, please share your screen.
One minute. Hello. See this screen, sir? Hello.
Yes.
Sir, my post presentation is regarding the prospective study in evaluating the factors affecting functional outcome in patients with floating elbow injury.
Okay. Your audio is slightly.
Hello?
If you could just make your voice louder, yes, that's better.
Hello. Floating elbow injuries are complex injuries due to the frequent association with severe soft tissue injuries and polytrauma. They have unpredictable functional outcomes. So this prospective study was aimed to evaluate the factors affecting functional outcome in such injuries. In the methods, 30 patients with floating elbow injuries were treated at level 1 trauma centers from July 2018 to July 2019, period of 1 year with a minimum follow-up of 9 months. The patients who were presented with floating elbow injuries were divided into 3 groups based on this intraarticular involvement, as similar to the floating knee, which was given by Fraser et al. The management of the floating elbow injuries was performed either in a single stage or multiple stages. It was determined that by the type of fracture, associated soft tissue injuries, and general condition of the patient. The outcome was assessed by disability for arms, shoulder, hands for dash, and manual performance for MIPS. The table shows the groups according to which the patients were categorized based on the involvement of articular involvement. Among the results, the overall incidence was around 16.09 per 1,000 patients, mostly caused by road traffic accidents, and all the cases were managed surgically. The majority of injuries will belong to group 1, which is only extra-articular involvement of humerus and either radius or ulnar both, and followed by group 2, while there were 4 cases of group 3, which is involvement of both intra-articular humerus as well as radius or ulnar. And age, gender, education or occupation, and arm dominance and mechanism of injury and duration between hospital arrival and surgery did not significantly affect the outcomes. However, open fractures in patients who are requiring stayed procedure were associated with poorer outcomes, which was significant. And also, delay in surgery for more than 24 hours also significantly increased the rate of complications. But there was no statistical difference in the proportion of patients who had nerve injury preoperatively and postoperatively on the faunal outcome in terms of functional outcomes. And there was significant improvement in dash to met scores, range of motion, pronation, and supination during follow. Performed and delay in surgery have a significant influence on the final outcome. Neuropraxic nerve injuries recover over a period of time and did not influence the final outcome significantly. Timely intervention and multimodal approach can lead to a good Hello? 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 Hello?
Yes, Dr. Praveen.
Yes, sir. Yes, sorry, sir. Sorry, sir. Actually, I had some I was posted an emergency report of call, sir. Hello?
Yeah.
Yes, sir. Hello?
So did you finish your presentation?
Yes, sir. Yes, sir.
Okay. Any questions?
Dr. Praveen?
Hello?
Dr. Praveen,
Yes, sir.
I have a
Yes, sir.
question for you that
Yes, sir.
you concluded that the anatomical level of fracture doesn't affect the
No, sir.
outcome.
We didn't find statistically significant result with respect to the anatomical level. However, we found that the intraarticular involvement patients had a lesser favorable outcome than the extraarticular group patients. But we couldn't
Actually,
get that significant level, sir. So because of which we couldn't state that fact.
What type of statistical analysis you used in such a critical study?
Yes, sir.
What
Sir,
type of
in the cell when in that, sir, we used for in cells where the value is less than 5, Fisher exact test was used for comparing numeral outcomes like
I'm asking
pronation,
about the
supination, RM.
statistical test. Dr. Praveen, I'm asking about the statistical test.
Paid t-test, sir. Paid t-test was used for numerical outcomes like pronation, supination, ROM, and chi-square test was used for analysis for prognostic factors like dash and METS scores, sir.
Actually, the question which I'm asking, why I am asking this question is that by and large,
sir.
most of us will agree that if the floating elbow involves an intra-articular fracture, then they are
Yes, sir.
going to have a poor outcome.
Yes, sir. Yes, sir.
And they will have a much higher impact in comparison to the delay in surgery or the other factors which you have highlighted in your conclusion. If you can show
Yes,
your
sir.
conclusion side, I would like to read it again. So I want to have your point of view over this again because your voice got missed out in between
Yes,
because
sir. Yes, sir. Actually,
there
yes,
was
sir.
a
Yes, sir.
call. There was a call at your end.
Yes, sir. I got a call. Yes, sir. Yes, sir.
So can you just show your screen again of conclusion and just the conclusion one?
Yes, sir.
Yeah. So if you can see that
Yes,
you
sir.
have said that type of surgery performed. So can you tell me what different types of surgery you performed in a floating
I mean,
elbows?
sir, in this actually, the type of surgery is meant by, sir, if it was done in a single stage or in a multi-stage surgery, sir. Actually, in cases where it's a polytrauma patient where we couldn't operate for a different fixation on the same stage, or we had some poor soft tissue condition or open injuries where we had to perform a second stage surgery. In such cases, sir, the second stage surgery patients who were operated had poor outcome in comparison to those patients who have been definitely fixed in the initial stage.
How many non-unions you encountered in such cases?
Sir, no, non-unions, no, we didn't have.
Because I personally believe that your outcome delay or poor outcome is more or less due to a non-union or delayed union. Because open fractures, I hope that you might be managing them with the fixators, and they may be landing
Yes,
up
sir.
in a non-union. And I
Sir,
am
actually,
asking, and you are saying there is no non-union. It
sir,
is so
actually
surprising for me.
26 cases were operated in the first stage sitting, sir. We had 4 cases which were operated in the second stage sitting, which second surgery, which had to be fixed, which had fixed in the second stage, sir. And overall, we had the poor
How many
outcomes at most
intra-articular
like for
fractures you encountered? How many
4, sir.
Intra-articular.
Sir, intra-articular, sir, on group 3 was the group 3, which was included both, was like it was 4, sir.
Actually, you have not mentioned this thing in your result.
Okay,
That's
yes, sir.
why.
Yes, sir. Okay, sir. Yes, sir. Actually, for I thought it was 5 slide limit, so I didn't include some related.
But that is an important part. Huh? I think for
Yes, sir.
I
Yes, sir.
believe that age, gender, education, occupation, side dominance. Every one of us are aware that they might not be having any role in the outcome.
Yes, sir.
But
Yes,
anatomy
sir.
of the fracture will definitely is going to have something which you
Yes, sir.
missed out in your results also. Okay, thank you. Thank you. Over to Dr. Maninder. Any other question? Or we can move ahead.
Yes, I think we can move ahead. Thank you, Dr. Amit. And is Dr. Narottam Das
Yes, sir.
ready? Please.
Yes, I am ready,
Start
sir.
sharing.
Sure, sir. Sir, am I audible?
Yes, we can hear you.
Good morning, all. My topic is on study on clinical and radiological outcome on arthroscopic fixation of acute AC joint dislocation with dog bone button and fiber tape. This
Dr.
study was
Narottam, sorry to disturb you in between, but we are getting a lot of requests for presentation.
So a lot of posters were accepted for this conference. All the selected posters which were accepted are displayed on the website.
Sir, mine was selected, sir.
Oh, yeah, I know you are there. I know you are there. So, in case, and only a selected few people were to present today during this live session. We have covered most of the live speakers. If at all anyone is left, kindly message, drop a message in the chat box so that we can take that presenter next, whosoever is left from that selected list. All other requests will not be able to take. Thank you. Now you can continue, Dr.
Sure, sir. Thank you, sir. So this study was carried out at CIO Safdarjung Hospital for a period of 18 months. Introduction. In literature, more than 100 surgical techniques have been proposed for AC joint stabilization, and it has become a Herculean task to find out an optimal treatment. So AC joint, which constitute about 3 to 5% of shoulder injuries. So the treatment includes fixation of AC joint using K-wire, hook plate, Bosworth screw, and so on. Henceforth, we have chosen Doacon button, which is a pre-contoured titanium button that allows use of multiple fiber tape sutures for AC joint reduction. So the objective was to evaluate clinical outcome, radiological result, and look for any complication after arthroscopic fixation of acute type 3 to type 5 Doacon classification of AC joint dislocation using dog bone button and fiber tape. So method, it was a prospective international study carried out among 30 patients with acute AC joint dislocation who presented less than 3 weeks old between October 2018 to March 2020. So preoperatively, CC distance was documented and patient was taken for surgery. Surgical techniques include patient was made to lie in standard lateral position. Scope was inserted in posterior portal and jig was introduced jig was introduced in anterior portal. A guide pin was inserted under image intensifier and using a suture lasso. Both dog bone button and the fiber tapes were retrieved and fixed after satisfactory reduction. In post-operative period, shoulder evaluated radiologically and clinically and compared with contralateral normal side for pain, activity level, and ROM using constant score. The time taken to return to work and patient satisfaction with cosmetic appearance were also noted. Complications were noted and clinical radiological follow-up was done for 18 months. Results: constant score improved at an average of 48 at 6 weeks and 89.83, ranging from 63 to 98 at final follow-up. Mean CC distance was significantly decreased from preoperative 20.9 to 10.3 at 1 year follow-up. There was significant improvement in range of motion in post-operative period with mean abduction of 128 and mean flexion of 148 in these patients. Average taken from surgery to get back to work was 4.2 months. This is a clinical picture of range of motion of a patient with grade 5 AC joint dislocation. Complication, there was partial loss of reduction among 5 patients, which included 2 patients during intraoperatively, which was fixed using K-wire. And the take-home message is fixing is acute AC joint dislocation using arthroscopical assisted dog bone button is a reproducible and easy technique which gives reasonably good clinical result, but may require improvement in biomechanics to prevent early loss of reduction, and additional strengthening with autogenous tendons may be suggested. Thank you.
Okay, thank you, Dr. Narottam. Very good presentation. Dr. Amit, any questions from him?
I think a good presentation. Just want to ask one thing only, that you have included Rockwood type 4 also in your presentation.
Yes,
so during the how you achieved reduction in all the cases of Rockwood type 4? Did you require to open up also few cases?
So only there were 2 cases of type 4, and which required both of them required openings.
Open procedure. So
Means arthroscopical assisted plus the slight bigger incision for reduction, sir.
okay, because this has a usually buttonholing through the trapezius.
Yes,
That's
sir.
what I'm asking. All
Yes,
right.
sir.
So you opened up a bit also.
Yes, sir.
And all these procedures you performed in the lateral position.
Yes, sir.
Arthroscopy lateral position was done.
Yes, sir.
Because usually AC joint fixation, usually arthroscopically we prefer in a beach chair position. So any specific peculiarities of choosing a lateral position?
So I think it was my mentor Dr. BP Sharma, who used to prefer arthroscopy in lateral position.
Lateral.
Yes, sir.
Thank you. Thank you. And Dr. Samar? Yes, sir,
I have
Dr.
a question.
Sir.
You said in your conclusion that's easy technique. Do you think that this is, sort of a very reproducible technique? And I think it's, sort of slightly more advanced technique, which would have a learning curve. My question is, did you actually put the coracoid drilling arthroscopically? Did you just visualize the AC joint arthroscopically?
No, sir. We visualize the coracoid arthroscopically, and actually, I got your point, sir. There was many a time there was difficulty in passing the guide pin from clavicle to coracoid. So there was a need of image intensifier also.
Right. But you were able to visualize the undersurface of the coracoid arthroscopically, and that's where the guide pin came out of. And that's what you aim to do in your surgery, or how did you actually do it?
So actually, there was difficulty with 30-degree arthroscope, visualizing the base of the coracoid.
Okay.
So it required 70-degree arthroscope, sir.
Okay. And lately, the fixation of AC joint injuries has gone more from the synthetic fixation to more of allograft or autograft fixation, more of a biological fixation. Any comments on that?
Yes, sir. That's what we after the whole study. That's what we felt. This should be augmented with autogenous grafts, sir. That will be better. That will give better outcome.
Okay. Right. Thank you.
Thank you, sir.
Now I think we have. So if
Dr.
you stop your sharing.
So,
Dr. Samar?
can we request Dr. Amit Moore to present his paper, which was missed during the earlier session? Dr. Amit?
And we have Dr. Shiv Shankar Jadhav as well, Samar, who's also waiting to present his poster.
Okay, sir. So, should we take him after Dr. Amit?
Yeah. And just to inform you that you will, whoever is waiting for the presentation but is not in the list, you will get a certificate of presentation. This is basically to decide the top 3 posters for the prizes. So only a select few posters were selected for that, for the actual presentation, because of lack of time. We could not accommodate everybody in the session, the time that we had for the posters.
Good morning, sir. Am I audible?
Yes, carry on.
Sir, my topic of the paper presentation is outcome of the arthroscopic shoulder stabilization in the anterior shoulder instability using all suture anchors. Glenohumeral instability can be due to the trauma, due to the generalized laxity, can lead to the complete dislocation. And the most common cause in the anterior dislocation is the traumatic. All suture anchors are being increasingly used nowadays in the capsulolabral tears. The advantage of these are non-rigid materials, reduced bone material, increase the potential of the fixation point, and the no delay in the bone formation. How the suture anchor is applied? This is the technique. Aim is to evaluate the outcome of the arthroscopic shoulder stabilization procedure in the patients with the anterior shoulder instability using all suture anchor. Material and the methods. This study included the 20 patients, included the 16 male and the 4 females with the mean age of 28.2 years, range from 18 years to 40 years, who underwent the capsulolabral repair from the June 2018 to the June 2020. Preoperatively, clinical examination and the MRI done, range of the motion assessed, and the apprehension test found positive in all of those subjects. Mean age at the first dislocation was 25.2 years, and patients were followed after every 2 weeks for 2 months, and then monthly for the 6 months, and then at the end of the 1 year. And a clinical assessment was done as per the raw score and the UCLA score. Results: the average follow-up period is 1.2 years. No failure in the form of the subluxation or dislocation till now. Range of motion was found to be compromised in not to be compromised in any patient after the completion of the 6 month and the 1 year till follow-up. This is the post-op raw score improved to the 88.7 from pre-op 36.2, and the UCLA score improved to the 31.6 from the 22.8. Subjects are satisfied with the stable and the mobile shoulder joint. This is the clinical photograph showing the full range of the motion after the capsular level repair with suture anchor. This is another photograph of the another patient. Conclusion: arthroscopic shoulder stabilization using all suture anchor is scarless, minimally invasive, and lead to the robust stability and the mobility, and return to the pre-injury level in the short span. Thank you, sir.
Thank you, Dr. Amit. Any questions from any of the panelists?
Yeah, Dr. Amit. So you say this is scarless, it has good rehab, this is robust. Are you what are we comparing this with? A normal suture anchor, a metallic suture anchor, or a biosuture anchor would also be robust. It will also give sutureless surgery. It will also give the same results probably. Dr. Amit?
Dr. Amit, you got the question?
No, sir.
Can you go to your conclusion slide, please? The one before, thank you. Yeah, no, yeah. So you say that using all suture anchor, the surgery is nearly scarless. Would it be any different if you're not using all suture anchor, if you're using metallic or a biosuture anchor? Would it be any different? Would that not be a nearly scarless surgery?
Sir, it will also be scarless.
So, and next, would that not be a minimally invasive surgery?
That can be also minimally invasive, sir.
Would that not give return to pre-injury level in a short span?
It can also.
And would it not be good for robust stability and mobility? Do you mean to say these all suture anchors are more biomechanically stable in the early post-operative period?
No, sir. Actually, I am not comparing those. I am in our patients. I use all suture anchors, and these are my results.
So when you are doing a study like this, wherein you are using a newer method of fixation, then you always compare it with the established method of treatment, which is there in the textbooks for a long period of time. If this technique, I agree that bone lysis, removal, revision surgeries will become more easier with the all suture anchor because there is no metal or artifact. Repeat MR scans will not have any scatter. But then the conclusions that you have drawn from your study are not the correct conclusion that you should have drawn from your study.
Yes, sir.
Dr. Maninder?
No, I don't have any questions. Thank you.
Should we go on to the next presentation, sir?
Yeah.
Thank you, sir.
Thank you, Dr. Amit. Please stop your screen sharing. Can I invite Dr. Shiv Shankar Yadav to give this presentation, please?
Good morning, sir.
Good morning.
Hello. Good morning, sir.
Good morning.
Good morning. You can continue.
So am I audible?
Yeah.
Yes, you are.
Yes, sir. So my today's poster presentation is on total elbow arthroplasty in a rare case of giant cell tumor of humerus, sir. Introduction: giant cell tumor forms 4 to 5% of all bone tumors, of 20% among the all benign tumors. It is usually single aggressive local and accounts for 5% of metastasis with 3% of malignant changes. It's most commonly seen in 30 to 40 years of age group It's most commonly affects the distal femur, distal radius, proximal tibia, and proximal humerus. But the occurrence in distal humerus is pretty rare. Radiologically, we can see a giant cell tumor presents as a soap bubble appearance, which is a radiolucent lesion. Giant cell tumor is usually treated with intralesional curettage, either with bone cement packing or bone grafting. In this case report, which I am presenting, a patient was reported in November 2019. He was a 50-year-old male who came with complaints of pain and swelling over the right elbow since 3 years. On examination, a diffuse swelling which was noted around the distal humerus. The local temperature was raised and tenderness was noted all over the surrounding area. Margins of the swelling were ill-defined with soft, doughy, bony hard, mixed consistency was present. The overlying skin was non-pinchable. It was fixed to the underlying tumor. There was a fixed flexion deformity of 60 degree along with range of motion of 30 to only 80 degrees was noted, which was painful on further passive movement. Supination and pronation was also painful and restricted. A radiograph showed an expansile osteolytic lesion, which resembling a soap bubble appearance. MRI scan was also done, which depicted an expansile mass involving the articular surface of the distal and humerus, which leads to the cortical break with extraosseous extension into the adjacent soft tissue. Patient was advised cytology, and the report was suggestive of giant cell tumor. Patient was operated with total abscission or excision of the distal humerus along with total elbow arthroplasty. A cemented total elbow prosthesis made of stainless steel was used. A posterior medial skin incision was taken. Soft tissue was dissected and the ulnar nerve along blood vessels were identified and isolated. The olecranon process along with the radial head was excised and removed. The limb was kept in full extension with an above elbow slab. At 8-month follow-up, the patient had free range of motion from 10 to 110 degrees without pain along with no evidence of reoccurrence. This discussion, giant cell tumor of bone mostly occurs anomalous and expansile lytic lesion with thin cortex and in later stages may breach the cortex of the bone, which happened in this case. The most important histological and morphological feature was the multinucleated giant cells which may have 100 nuclei with prominent nucleoli. The distinguishing feature of giant cell tumor from other bone tumors or the osteogenic lesions that have benign osteoclast is that the surrounding mononuclear and the multinucleated cells that are small in size have nuclei similar to those found in the giant cells. Surgery is always the treatment of choice. Excellent functional outcomes and less recurrence rates have been seen in wide dissection of tumor and total elbow arthroplasty. In conclusion, GCT is a rare condition in lower end humerus, and prompt and accurate diagnosis of the same and total elbow arthroplasty management led to successful and acceptable functional improvement of our patient. Thank you, sir.
Any questions, Dr. Amit?
I think he has a very good case report in that sense. Just a question that is there any specific reason for choosing arthroplasty over arthrodesis? Because the patient is already 50
Yes,
year old. Yeah, and your X-ray is still appears to
sir.
be the lateral view appears to be a bit somehow I don't know subluxated or dislocated or it's an oblique view, but not able to judge it properly. So can you highlight that also? Yeah, please. Over to
Yes, sir.
you.
The patient wanted a free range of motion, sir. His first the motion was only 30 to 80 degrees, which he was not able to perform his daily routine activities, sir.
Okay, the next
So
question
doing joint
related to this is
elbow arthroplasty.
the next question
Yes,
related to
sir.
this is because this is a huge tumor, the collateral ligaments must have been
Yes, sir.
resected out along with the tumor. So how you are,
Yes,
although
sir.
you have put a constrained processes, still some collateral ligaments are required to maintain the normal integrity of the joint. So have you find any difficulty intraoperatively or postoperatively in that scenario?
Yes, sir. The patient after the surgery was not able to perform the routine activities like previous, but with physiotherapy and with daily routine physiotherapy, he was able to do routine activities, not like previous, but much better than the when not performing the activities.
And the other question which I have asked about the X-ray, which you have shared with us, this
Yes, sir.
later
The X-ray was
appears to be
a little
odd.
bit. Yes, sir.
So is it normally located elbow, or is it a dislocated one? Because I could able to appreciate some calcification kind of mass in front of coronoid process also, and a huge gap between your humeral processes and the coronoid process. So with this X-ray, I am doubtful that patient could able to achieve a good range of motion.
No, so the X-ray was taken in the oblique view. It's not a proper lateral view. I agree with that, sir. But the patient at follow up, the patient was able to perform his activities, sir.
But actually, if you see a lateral view, your ulna and radius appears to be quite a good in a lateral position. Even your humerus appears to be quite a good in a lateral position. But the distance between the processes and the coronoid notch is too much. So I don't know.
Yes, sir. Yes, sir.
Okay, over to Dr. Samarth sir and Maninder sir.
Dr. Shiv Shankar, are you happy with the cementing of the ulna?
I agree, sir. There, it's not a proper cementing, sir. I agree with that.
How do you do cementing for the ulna? What technique have you used for cementing this into the ulna?
So the cement was the bone cement was used with vancomycin antibiotic within it, sir.
How was it put into the ulna?
So we made a hole in.
You made a hole in the ulna, then?
Yes, sir.
You made a hole in the ulna and did a trial of the implants, and before putting the final implant, how did you put cement in the ulna?
So we used the cement syringe, cement injected syringe, sir.
A cement injected syringe was able to go into this
Syringe was
ulna.
used for injection of the cement, sir. Yes, sir.
The normal cement gun, you mean to say?
Yes, a normal cement gun, yeah.
Is it a special cement gun? Because most cement guns are unable to negotiate into the ulna.
No, yeah, it cannot go, I think. Normal cement gun. That's why Dr. Samarth has
So
asked.
we tried with that, sir, but the cement spilled out, so we manually did it with our fingers, sir.
Okay, so another technique to do that is because most people around the world face this problem putting cement into the ulna, which is why your X-ray doesn't look too good, especially with regards to the ulna. So what people do is take very liquid cement in the initial stage, and they inject it through a small normal syringe, 20 ml syringe, put it in a 20 ml syringe, and through that 20 ml syringe, they push it into the ulna rather than a cement gun. With whatever little packing that you can do a pressurization, that is done with a syringe instead of a cement gun. That is what we do at our institute. I don't know if Dr. Amit or Dr. Maninder can have some other tricks up their sleeves, but certainly I've done quite a good number of elbow arthroplasties, but I've always faced this problem, and this is the catch that I have. And another thing that I completely agree with you on, Dr. Shiv Shankar, is in these cases, because it is a completely constrained and hinged prosthesis, so even if you don't have collaterals, these patients do really good for at least for first 5 to 10 years.
Yeah.
If not 10 years, 5 years.
Yes, sir.
Yeah.
Dr. Amit, Dr. Maninder, do you have any experience with the cementing of the ulna? Any tricks?
Sir, we have been using a Riles tube attached to the same thing, a cut end attached to the 20 ml syringe, so that it may go a bit deeper, because that can go in that hole, not the cement spacer.
Perfect. We use an infant feeding cannula sometimes for that purpose.
Yes, sir. Yes, sir. Correct.
Perfect.
So I think wonderful, Dr. Shiv Shankar. And Dr. Samar sir, is there any more presentation, or can we wind up?
Maninder sir, is there anyone who wants to present now? We are done with all the selected ones. So if there is anyone else, we still have time for 2 short presentations. If someone wants to present the ones who were requesting, we can take in a presentation now, but it won't be considered for the prize. Dr. Varun, Dr. Nrutik,
I
Dr.
think they've
Kishan,
left.
Dr. Aditya, Dr. Varun, anyone who wants to present can go in. So should we call it a close for the session now?
I think that's, yeah, I think we should do that. Okay, so thank you everybody for such a great session. Thank you, Dr. Amit, for playing such an active part and judging the entries. We have other panelists who could not join in, but who've been listening in. We will be announcing the results in the valedictory session of the prizes of the poster session. So thank you all the presenters for such great, topics and poster presentations. So we're really thankful to all of you to make this a great success. And thank you, Dr. Samar, Dr. Dhananjay, who's made this sort of, poster session really interesting. And, more time. We actually allotted 1 hour, but we've taken more 2 hours now for this poster session. So
I think that was the basic idea of having this particular session, because the young people, young orthopedic surgeons who are presenting their work, they should get some insight, what is right, what is wrong, and how should they do it in a proper way so that they can go much higher and higher. Thank you so much, gentlemen, for conducting this session. I'm really thankful to you all, and all the best. I would expect to receive the result within a short time, right? All right, thank you so much. Join us in Hall A. We're having some very nice talks over there. I'm sorry I kept you out of it for almost 2 hours, but you can please join now. Thank you so much. Have a good day.
Thank you. Thank you, sir. Thank you, everyone.
Thank you, Dr. Amit. Thank you, Manindra.
Thank you,
Thank you, Dhananjay.
Thank you.
Thank you, sir.
so
Thank
much.
you, everyone. Thank you so much. Thank you.